So, good evening, everyone. We will start today's International Day CME Epilepsy Day. Now we will have the presidential address by Dr. L. Murugan sir, our president of Tamil Nadu Association of Neurological.
Secretary, thanks for all the wonderful work you're doing. Thanks welcomes all the participants in today's CME to this wonderful topics, which are basically to commemorate the International Epilepsy Day. It's a very interesting list of topics and speakers, starting from the absolute basics, which will be useful for everyone, to the complex surgical interventions. We thank all the speakers for agreeing to present their topics here, taking their time out. We also want to announce that the Secretary will be giving more details that TANS 2024, our annual conference, is being scheduled to be held in April 5th to 7th in Roopesh at Sterling Resorts, Cornwall. Our Secretary will provide more details about this. Hope all of you find today's topic very useful. Thank you so much. Back to our Secretary.
Now I request Dr. Suraj Jayabalan sir to give a few words.
Thank you, Dr. Rajesh Babu. Yes, our President, Dr. L. Murugan says, I welcome everybody, Dr. Dinesh, Nayak, and other speakers for their wonderful talk today. I think it will be very helpful for each one of us, both the neurologists and neurosurgeons here. Without wasting our time, we'll just proceed with the academic event. Thank you. Thank you very much.
Now it is time for the Secretary. I welcome you all for this today's CME on on the eve of the International Epilepsy Day. The International Epilepsy Day falls on the second Monday of February every year. And to commemorate that, we are celebrating this program today, the CME program, which I thought will be useful to our postgraduate students and all the practitioners, because we have included the topics like basic of EEG, and then emergency management in epilepsy, and then surgical topics. So all the three will cover everything. Dr. S. Muthukani, who is going to give a talk today on the EEG basics. And Dr. Muthukani did his MBBS from MMC at 2010, MD from Madras Medical College, DM Neurology from AIIMS 2017, and DNB Neurology, passed out, and All India Gold Medalist also. And work experience, Senior Resident Physician, Neuro Department AIIMS from 2015 to 17, Clinical Fellow Epilepsy in Amrita Institute, Kochi from 2018, and Consultant Epileptologist in Apollo Hospitals, Madurai. Current position, Consultant Neurologist at Apollo Hospital, Chennai, and publications, more than 12 publications, and currently doing 3 projects. I welcome you, Dr. S. Muthukani sir, for your talk.
Thank you very much for the kind introduction, sir. At the outset, I would like to thank Dr. Roopesh Kumar sir and the TAN Society for inviting me to talk about some basics of EEG. These are my disclosures. EEG is one of the most hated topics, not only for residents and technicians, even for faculty also. It's sometimes tedious to grasp, and it requires constant attention and repetition to understand the EEG. If I can convey only 50% of what I was trying to convey with a 25% of retention rate, I would take that as success for this today's talk. But if you don't pay attention, none of this will make sense. With that disclosure, we'll start. Before talking about the basics, I would like to tell something about the pioneers of EEG. Way back in 1800s, Dr. Richard Caton, he was a British physician. He first recorded the electrical activity from the brains of the animals. Later on in 1920s, Dr. Hans Berger. He was a German neuropsychiatrist, and he was the one who recorded the first human electroencephalography. In fact, he coined the term electroencephalogram. Later then, Dr. Yerna and Dr. Frederick Gibbs, they described various EEG manifestations of various types of epilepsy, and the typical 3 Hz spike and wave discharges of petit mal epilepsy that was also described by them. If you take India, Professor Baldev Singh, he was the one who first did EEG in India at Christian Medical College, Vellore. We all know that electroencephalography, that is EEG, which is basically recording the electrical activity from the cortex of our brain, which will record predominantly from the cerebral convexities, not from the cell sites, predominantly from the gyri. It is actually nothing but a fluctuating sum of excitatory and inhibitory post-synaptic potentials from the apical dendrites of the pyramidal cells that is actually concentrated in the layer 5 of our cerebral cortex. This cortical electrical activity is actually getting modified from the subcortical structures, that is thalamus and ascending reticular activating system. In fact, thalamus is called pacemaker of our electrical activity. So that is continuously modulating the cortical electrical output. We know that neurons are the primary functional units of the brain. They are actually quite excitable, and they use basically electrical impulses to communicate with each other. When the action potential is traversing across, this is the pyramidal cell, and this is the apical dendrite, and this is the axon, which is covered by the myelin sheath. They are the basal dendrites, and that will have multiple number of synapses. When the action potential traversing across the axon, and when it reaches the level of synapse, it releases multiple neurotransmitters. Depending upon the neurotransmitter release, whether it is sodium channel release or whether it is a entry of sodium channel into the post-synaptic membrane, whether it is sodium channel opening or chloride channel opening, there will be generation of excitatory post-synaptic potentials or inhibitory post-synaptic potential. EEG is nothing but it is actually a fluctuating sum of these post-synaptic potentials. These dendritic generators are actually vertically oriented to the surface. So they're actually perpendicular, which will be picked up by the recording electrodes. If you look at these dendrites, apical dendrites, the superficial end will be relatively negative, and the deeper end, which is close to the soma, which will be relatively positive. So it will be acting like a dipole. To record or to produce any changes in the EEG, we would require at least 6 to 10 centimeters square of cortex to discharge synchronously, because all these post-synaptic potentials or the field potentials are very small in amplitude, which may not be we may not be able to record it. Only when there is synchronous firing of thousands of neurons, which is covering at least 10 centimeters square of cortex, then only it will be producing some appreciable changes in the scalp EEG. And the important hardware in the EEG is a differential amplifier, which I will come to that shortly. This flowchart depicts how the EEG machine works. We will put multiple electrodes over the scalp, and they will be connected to the differential amplifier. Differential amplifier is nothing but, for example, if you have a derivation or a channel, there will be 2 inputs. One is input 1 and another one is input 2. This is basically differentiating or subtracting input 1 from input 2. And the remaining electrical potential, which will be amplified, that is why it is called a differential amplifier. And that output will be going through multiple analog filters. They're called high frequency filter, low frequency filter, and notch filter. High frequency filter, which will be fixed at 70 Hertz. That means above 70 Hertz activity, which will be filtered. Low frequency filter, that will be fixed at 0.3 to 1 Hertz. So that means EEG, that machine will filter out the electrical activity below 0.3 Hertz or below 1 Hertz. And notch filter to avoid any electrical noises, that is usually fixed at 50 Hertz or 60 Hertz. After passing through all these filters, then again it gets amplified. Then from the analog information, it will be converted into digital information, that is called analog to digital converter. Then that further information which will be displayed on the screen, and it also can be stored in the computer. This is how the EEG machine works. Why should we have all these filters? Just to highlight that, I am showing this picture, this is a snapshot of an EEG. This is basically nothing but a chewing artifact. So patient is swallowing, like chewing and swallowing something. So this chewing is producing multiple artifacts. So here you can see the low frequency filter at 1 Hertz and the high frequency is fixed at 70 Hertz. But if you change the frequency filters to something like this, low frequency at 1 and high frequency at 10. So that means above 10 will all be filtered. We don't see anything above 10 at all in the EEG. So now the chewing artifact will actually appear like a generalized spike and wave, which is like more dominant over the temporal chains. So the normal chewing artifact, which is like, it's a benign artifact. Now it appears like a generalized spike and wave. That is how it will confuse us. That is why we always need to check that the filters are in the correct frequency range. How do we place these surface electrodes? We follow this international 10-20 system. We use almost close to 19 set of electrodes with the 2 references, one in the each ear lobe and 1 ground electrode. Here, the odd number indicates these electrodes will be placed over the left side of the scalp, and the even number indicates that they are placed over the right side of the scalp. And Z means central, that means it's frontocentral, midline central, and posterior or paretocentral. And the suffix, it's like the prefix itself will be self-explanatory. FP means frontopolar, frontal, central, parietal, and occipital. That is where these electrodes will be placed. Once you place the electrodes, then we will start recording the EEG. In this, we need to know a few things. One is called derivation. What is derivation? This is nothing but a recording of the potential difference between an electrode pair. For example, if you connect FP1 with the F3 or FP1 with the F7, this is called a derivation. And what is montage? It is nothing but basically how do you arrange all these derivations in a specific order? How you look at that? It helps us to systematically visualize the field of electrical activity of the brain. There are 2 types of montages which we commonly use. One is called bipolar montage. Another one is called referential montage. Bipolar montage means here you collect the sequential electrodes which are placed nearby. For example, FP1 to F3, F3 to C3, C3 to P3, and P3 to O1, like that. This type of bipolar montage called double banana type of bipolar montage. Here you can see FP1, F7. So in a single derivation, this is input 1 and this is input 2. In the first derivation, F7 in this input 2, but in the second derivation, the input 2 will become input 1. That is how the arrangement of electrodes are. That is the importance of this having bipolar montage. What we look into this bipolar montage, here we try to look for phase reversals. That means that indicates where is the maximum negativity in the human brain. The another group of montage is called the referential montage. The common referential montage which we use is common average reference. That means in all derivations, input 2 will be same. So the input 1 will be different, but input 2, it will be an average electrical potential of all other remaining electrodes. So FP1 will be compared with reference, F3 compared with average, C3 again compared with the average reference. This will give us basically an idea of the exact amplitude of a particular electrical potential. This bipolar montage and referential montage are actually complementary to each other. Generally, we use both of them. What are the rules of polarity on EEG? This is very important. If you take 2 channels, that is input 1 and input 2, suppose if input 1 is negative compared to the input 2, that is positive, it will produce a upgoing deflection in the EEG that is called surface negative wave. Just to put it in a simple words, this deflection will always move towards negativity. For example, if you take input 1 and input 2, input 1 is more negative than the input 2. So that's why it moves towards input 1. Suppose input 2 is more negative than the input 1, then it goes towards input 2. That is easy to remember like this. I think this example will clarify the doubts on the polarity of EEG. For example, in example A, FP2 and F4, FP2 is negative compared to the F4. So that means it creates a deflection towards FP2. It's the surface negative. The second B1, FP2 and F4 both have similar electrical potential, so that cancels each other and it produces isoelectric line. In the third example, FP2 is -10, but F4 is +10. So that means -10, that means becomes -20. So it goes bigger and it moves towards FP2. And the last example, if you take, this is +10 and the F4 is 0. So here, this becomes more negative than the +10. So it goes towards F4. How do you interpret a particular EEG? We look into several aspects. What is the polarity of that particular waveform? What is the frequency of that particular waveform? What is the amplitude? What is the morphology looks like? Whether it looks like a spike wave, sharp wave, or polyspike wave, or just slowing. Where it is situated, whether it is in the frontal, temporal, parietal, or occipital. And whether that particular waveform is reactive to a particular stimuli. And we also check the symmetry. That is all in conjunction with the particular age and state of the patient, because a particular waveform may be normal for pediatric age group, that may be abnormal for the adult age group. So we need to know the age of the patient and state of the patient before commenting on any of these things. That is very important. These are the frequency of common waveforms. We know that delta is less than 4, theta is 4 to 7, alpha frequency is 8 to 13, and beta is above 13 to 40, gamma is 40 to 80, and above 80 will be called ripples. What is alpha rhythm? It is the most posterior dominant rhythm. It happens only in the awake state, especially when the patient is relaxed with the eyes closed. If they open the eyes, it gets attenuated. That's called reactivity. And we know that the frequency of alpha is 8 to 13 Hertz. And it generally produces a sinusoidal waveform in the occipital regions. If you compare the right side with the left side, generally the alpha rhythm has having higher amplitude over the right side. But if you want to say a particular side alpha is abnormal, if you take the voltage criteria, there should be a difference of at least 50% between two sides. Or if you take the frequency criteria, we know that the common frequency is 8 to 13. There should be at least 1 Hertz difference between the two sides. Then only we can call that as significant. Comparing these two things, like amplitude versus frequency asymmetry. Frequency asymmetry is more significantly indicating a particular focal abnormality than the voltage asymmetry. So whenever you get a frequency asymmetry, that is very, very important. That generally indicates an abnormality on the lower frequency side. So this picture depicts the normal alpha. When the patient closes the eyes, this is the blink artifact. So when they close the eyes, you see the normal alpha, and when they open the eyes, the alpha disappears. Again, when they close the eyes, the alpha again reappears. So this is called reactive alpha. That is most dominant rhythm over the occipital regions. You can see clearly. This is a bipolar montage. If you put the same thing in the referential montage, you can see clearly that the amplitude is maximum over O1 and O2. It also having some representation over the parietal regions also, but it is maximum over the occipital regions. And this is the blink artifact. What is the protocol we should follow for a routine EEG? Always we should ask for a sleep deprived EEG. We should ask the patient to sleep for only 3 to 4 hours during the previous night. If you have a patient with a suspected epilepsy, you should always have an awake recording along with a sleep recording. Try to obtain natural sleep as much as possible, but in children it may not be possible all the times. In those cases, we can use triclofas or pedicloryl. We can use that in the dose range of 20 to 50 mg per kg, but dosing up to 100 mg per kg has been proven to be safe. How much duration you need to record the routine EEG? Generally, it's recommended at least 20 minutes of awake state with 20 minutes of sleep recording. But suppose if you have only awake recording, you should record for at least 30 minutes. That is the usual protocol we follow for the routine EEG. What are the steps of recording? Once you connect the electrodes, just to check calibration, we need to check the impedance, whether the impedance is okay. Then you start recording the background activity, like you start recording the EEG, check the background activity. and check for its reactivity, like eye opening, eye closure, and give some mental arithmetic, so it gets attenuated. We also use various activation procedures like hyperventilation and photic stimulation. Always make sure that you keep the high frequency at 70 and the low frequency at 0.1 to 1 Hertz. If you find any artifacts, try to identify and remove those artifacts. And always check the patients. If there is any suggestion or suspicion for any electrographic or electroclinical seizure, always test the patient during the seizure and inform the physician about all these changes. What changes the waveforms we record? It depends upon various factors, like how these waveforms are getting changed. Whether it is the distance of the recording electrode from the source, what is the reference we use, whether it is a referential montage versus bipolar montage, how the generators are actually oriented, whether they are perpendicularly oriented or parallel to the surface, and what is the volume conductor, what is between the discharge and the recording electrode. Generally, we have the multiple layers of scalp. So generally, it goes through the multiple layers of scalp and gets attenuated. The high frequency waveforms are actually filtered through the scalp layers, and generally we do see this usual range. This is the International Federation of Electroclinical Society. They criteria for the epileptiform discharges, that means spike or sharp wave. When do you say it is a spike, or when do you say it is a sharp wave? It should be a transient or paroxysmal abnormality that should stand out from the background activity with a usual with a duration of 20 to 200 milliseconds. 20 to 80 means it is spike, that is very spikier, and from 80 to 200 it means sharp wave. They should have a physiological field. For example, if you have any abnormal activity which is restricted to only 2 electrodes, then it may be an artifact. So always you should look for a physiological field on the scalp. Generally, a spike or sharp usually disturbs the background activity. That means it will have an aftercoming slow wave. And main component of this is generally negative. That means it's it will go up in the EEG, and its amplitude is variable depending upon the intensity of the source. You can see in this picture that you can see clearly a spike wave. So this is a spike followed by an aftercoming slow wave. It is seen over the right side. So even number indicates right, and it's a temporal chain of electrodes. So you can see that's the right temporal spike and spike followed by an aftercoming slow wave. Why are we stressing that we should always have a sleep recording? This boy had at least 4 to 5 episodes of seizures. All episodes happen during night when the child is sleeping. He had undergone multiple awake EEGs, and all the EEGs have been reported normal. But when we recorded the sleep EEG, when the child was sleeping, you can see a significant activation of bilateral centrotemporal discharges called Rolandic spikes, indicating that this child is having a Rolandic epilepsy. And in fact, he also had a seizure during that time of recording. The seizure came from the right side centrotemporal region. So the even number indicates the right. And this is the parasagittal group of chains. And this is the temporal group of chains. You can see that the seizure is actually starting from the right centrotemporal region. And you can see the evolution, how it starts spikier, then it becomes slower, and it evolves over that region with a phase reversal across F4, T4 after some time. We had another patient who was like 13 years old girl. She was having she had normal birth and development with seizures in the last one year. She had till now 5 episodes of seizures, like all were generalized tonic-clonic seizures. But the patients were in fact, like the girl was also categorically saying that the seizures always started in the right hand with the version, and the relatives are saying it probably to the right side. She also gets some jerks, and that too also, like even though it was on the both hands, she felt it's more on the right side. Clinically, everyone would suspect that this is a focal epilepsy. She started having right hand jerk. Actually, she was started on oxcarbazepine with a very good compliance. But even after taking oxcarbazepine, she was having seizures. When we did the EEG, you can see clearly that she's having multiple bursts of generalized spikes with a frequency of 4.5 Hertz. That clearly shows that she's having a generalized epilepsy, most likely juvenile myoclonic epilepsy. And We know that all the sodium channel blockers are actually contraindicated. In fact, they can worsen the seizures. Oxcarbazepine is one of the sodium channel blockers. We just stopped oxcarbazepine and we started her on levetiracetam, and her seizures completely subsided and under control now. That is the importance of doing EEG. That will help us to find out what type of epilepsy she has or what type of syndromic epilepsy she has. That is why we record EEG in all patients who are suspected to have epilepsy. When recording the electrical activity of the brain, we also record some non-cerebral waveforms. They are actually artifacts. They are nothing but they are unwanted signals generated by sources other than those of interest, and they are not of any clinical value. There are multiple types of artifacts. Some of them are physiological, some of them are non-physiological. We need to be aware of all these artifacts and we need to neglect all these things. We should not label any artifact as epileptiform abnormality. That is the importance of knowing about artifacts. I'm not going into delve on that. Another important thing, I think it's more important for the neurosurgeons about what is a breech rhythm. Like whenever we operate a patient, whether it is a craniotomy or craniectomy or some burhole evacuation, what happens? You are creating a hole or a defect in the scalp or the skull bone. So generally the skull bone or the layers of the scalp actually acts like a filter. It filters out various electrical activity. When you remove that barrier, then the waveforms will appear more spikier and the amplitude will be more and the frequency will be more faster than usual. Sometimes this breech rhythm can be misinterpreted as epileptiform. That is why we should know about this breech rhythm. For example, here you can see this patient had undergone hemispheric disconnection, hemispheric surgery. Here you can see compared to the left side, this is odd number. This is the right side, even number. You can see there's a significant difference in the amplitude in the right frontocentral region, which is like kind of phase reversal across C4. You can see that clearly the amplitude is different. The frequency is faster and it's more spikier. This is a classical breech rhythm. This is nothing but a physiological thing. We don't need to worry about this. What is the importance of misreading EEG? We should know about this because if you wrongly label a patient with epilepsy, it has huge physical and psychosocial consequences. It will lead on to unnecessary treatment with anti-seizure drugs with their side effects and the cost. And once you label them as epileptic, then it's very, very difficult to undo a once wrongly labeled EEG. It may result in repeating EEG multiple times. Sometimes they may require long-term video EEG just to document that they have a normal EEG. And it can also lead on to some medico-legal complications with the wrong diagnosis and treatment. I would conclude my talk with these take-home messages. We know that epilepsy is a clinical diagnosis, but EEG is a very important clinical investigation for any patient with epilepsy. It helps us to classify what type of seizure they have, whether it is a focal seizure or it is a generalized seizure. If it is focal, where it is coming from. It also helps us to classify a particular epilepsy syndrome, whether it is genetic generalized epilepsy or some sort of syndromic epilepsy in childhood period. Always try to record sleep because only during sleep there will be potentiation of epileptiform discharges. It's not like underreporting or over-reporting of EEG which is important. The correct reading of EEG is of paramount importance, not about under-reporting or over-reporting. Try to report or read EEG properly. When you combine this EEG with a video, that is video EEG, that is actually a level 1 evaluation for any patient with refractory epilepsy. Dr. Dinesh Nayak sir will be talking more about the video EEG parameters. I stop here and I once again thank you for the patience.
Now I invite Dr. S. Dinesh Nayak for his lecture on seizures in the emergency department, how to approach and how to manage. Dr. Dinesh Nayak sir is at present Director, Department of Neurology and Advanced Center for Epilepsy, Gleneagles Global Health City, Chennai. Major achievement, setting up of level 4 epilepsy surgery center, Chennai and Bangalore. Over 400 epilepsy surgeries over last 13 years. Actively involved in conducting and teaching at NESSAN EEG workshop. The honors and awards and publications are Dr. S.M. Muniratnam Gold Medal for highest marks for the final MD General Medicine examination. Dr. P. N. Berry Scholarship for Training in Intracranial EEG at King's College Hospital, London, UK. Over 50 publications in national and internationally peer-reviewed journals, 10 chapters on textbooks. I welcome you, Dr. Dinesh Nayak, sir, for your lecture.
Thank you, Rajesh. Thank you so much. Very kind of you to have invited me for this International Epilepsy Day celebration. Thanks, Dr. Murugan, Dr. Suresh Jaybalan. Thank you very much for this kind invitation, and it's a pleasure to be here. It's a very nice talk, excellent talk by Dr. Muthukani on the basics of EEG. I think he did a wonderful job. And if the retention rate is, I'm sure the retention rate is, because he made it so simple and nice, that I'm very confident and sure that the retention rate is going to be 75%. So, so I think the talk was a great success. I'm going to talk not on video EEG this time. I'm just going to talk on a simple topic. It's a practical thing, which is what happens when we confront a patient with seizures in the emergency department. How do you do that? And what are the next steps? That's the basic theme of this talk. So it's pretty clinical. And how do you actually evaluate these patients? So that's going to be my thing. The point is that in the ER, when somebody comes, these are the three things. When somebody comes with a history of a seizure, something like that. So there are three basic questions. First of all, is it really a seizure? We'll come to that a little later on. And if it is indeed a seizure, then what kind of a seizure that is? And the important thing is, obviously there is a cause for it. So you would like to know what caused it. And then the most important thing is, how do you proceed further? So what should be done? Very clinical. And then the next important question that you have to ask at the ER is that, is it in a patient who is already diagnosed to have had epilepsy and is on treatment? Or is it the first ever seizure, or you don't know the past history? So these are the three scenarios actually. So that's the kind of an approach that one has to have. This is the framework on which we build up the story. So that's the important point is, I just go back. So is it a seizure? So that's the question. And because there are so many seizure-like episodes that can happen, which can mimic a seizure, but they're not seizures, or they're not epileptic seizures. I mean, in the broad way, you can say that, okay, this is a seizure, but they're not epileptic seizures. So there are several of them, and that can be very confusing. So syncope is the most common one, and you know that syncopal seizures. The point is that unfortunately, syncope itself, just a vasovagal syncope or a neurocardiogenic syncope, can have during that period of time when they lose tone and they fall down, at that time they may have some tonic stiffening. One or two jerks may be there, one or two myoclonic jerks, one or two clonic jerks, just one or two. And there can be a little bit of a post-ictal confusion. So they may actually mimic a true seizure. So that's a very important point. And so the history is extremely important. Stokes-Adams is an extreme form of that. If you have that cardiac, transient cardiac arrest, then they fall down and then they become all right. Parasomnia is another thing, where you have sleepwalking, night terrors, and just anxiety, hyperventilation, that, when the process of hyperventilation itself can produce some kind of a funny, dizzy feel, and, and the reaction time may slow down. So it may mimic some kind of a seizure with slight impaired awareness or something like that. So that's another very important point. And then another important category is what is called the stereotypies or tics. They have some funny motor movements which keep happening on and off, involving the face, the limbs, whatever it is. So that's another thing. And some people just have, they just daydream, they just stare. And just not every stare is a seizure, but just there are several daydreamers, and they just get lost in their thoughts, and they may appear and they may not respond to you quickly enough. So that can also mimic. So there's several such challenges that we have before you actually make a diagnosis of an epileptic seizure. And the most important of them all, the most common, of course, is syncope, but the most important of them all is this feature, which is the psychogenic non-epileptic seizures, which actually forms, a fairly large chunk of our patients with seizures. Around 20% of all seizures are actually psychogenic, non-epileptic seizures. But the problem is that, these are the patients who may also have true epilepsy. So there could be a combination of both. So that's another big challenge. It could happen in isolation, or it could happen as a combination with genuine seizures. The clues to the diagnosis here, generally the eyes are closed. And generally when the eyes are closed, they resist to eye opening. And they have lots of attacks. So something like, almost like status sometimes, or prolonged attacks. The signs are generally variable. One of the important things about an epileptic seizure is there's always something, stereotyped. But here the signs can vary. They usually, they do not come out from sleep. That's a very important point. Most of them will have it during the wakeful hours. And most of the time it occurs when there is an audience. It generally doesn't happen when they're single and alone. So that's why the circumstance in which a seizure happens is very important. So none of these is on its own sine qua non of psychogenic non-epileptic seizure, but when you take it in combination of various other things, then you can then say that circumstantial evidence suggests that this could be a psychogenic non-epileptic seizure. So that's the important point, that when we talk about seizures and seizure-like, and it's extremely important, when you're dealing with patients or people with seizures, you got to have a framework. And Dr. Muthukani very nicely, showed an example where, you clinically it may look like one, but then, you have the other test that helps you to make a proper classification. So that's very important to understand the classification, and the classification is always based on clinical. So therefore, all of us, every doctor should have this simple classification in mind. Seizures can be focal onset, it could be generalized onset, or many times you just don't know whether it is really focal or generalized, because the accuracy of your diagnosis depends on the quality of information you get. How good is the person who's reporting this? So if the quality of information is good, then you can say, oh yeah, this is a focal epilepsy or focal seizure, rather, let's put it that way. If it is, you can make a generalized onset when there is absolutely no focal symptoms or focal signs. So that's what it is. And in focal, again, you can have focal where the patient is fully aware. I'll show you some examples, but they're fully aware during the seizure. And they continue to have either jerking or they have some symptoms which suggest that it's a seizure, but they are fully aware. Or they could have impaired awareness. And again, a focal seizure can be motor. So you can have a focal motor seizure with preserved awareness, or you have a focal motor seizure with impaired awareness. And you can have non-motor, you just have, blank stare. You just become completely unaware of what is happening around you. Or you may have some autonomic symptoms, which is not visible to others. So they're non-motor. They only describe it. So that's what it is. And then a focal can then go on to become a bilateral tonic-clonic. It earlier used to be called secondary generalized, but now the new terminology is that you just call it focal to bilateral tonic-clonic. The motor, the generalized also has a motor, where it's obvious, you have this tonic-clonic, and then you have myoclonic and all that. But the other important point is that you can have non-motor, where you have, the patient gets completely densely absent, and that's classically seen in childhood absence epilepsy or juvenile absence epilepsy, where the patient is densely absent. So that's an important point. So that's what it is. in history, many times in the OPD, generally most of these diagnoses are made in the ER. In this particular case, it's going to be in the ER, unknown onset. So you have to keep your eyes and ears open to see whether there are, is it a focal or is it a generalized? Again, the same problem. So you may not be able to classify properly. So unknown onset, unclassified, you got to keep your eyes and ears open to every bit of understanding. The basic difference between focal and generalized is this. In generalized, it doesn't mean that generalized means, the whole brain is involved at the same time. No, it could have a focal origin, but this focal is never a single focus. It could be somewhere here, sometimes it could be there. But the most important thing is that it rapidly engages networks which involve the entire brain. That's what it is. So the speed at which networks are engaged, widespread networks are engaged very quickly. Cortical, subcortical networks get engaged very rapidly. Therefore, the entire brain gets involved. But the origin can still be, in one instance, it can be right parietal, as in this case. The next time it can be the left frontal in the same patient. But the engagement of networks is the same. The engagement of network is the same, but the irritability can vary from this to that. So, but that's the point. On the other hand, a focal involves very restricted networks. So, for example, the focus here is the hippocampus is going to just remain in that same ipsilateral hippocampus and its lateral temporal. At best, then it could spread to involve the other hippocampus through these local network, not a generalized network, and go spread to the other. It's still quite focal. And only when it goes beyond that, then it can become generalized. And that's what we call as focal to bilateral. So that's the way, that's the fundamental difference. Foci are the same, but the way in which these foci engage networks is what determines whether it's a focal or a generalized. So that's very simple. I just made it very simple as a concept. So the assessment in the ER where the patient comes is again the same thing. Was the attack truly a seizure? Was this seizure truly the first ever seizure in the patient? Why did the seizure occur? And the most important thing in the ER is, was the seizure a symptom of an acute neurological illness? Very important. The patient is not going to tell you, I have a neurological problem. No, you have to determine whether the patient has a seizure as a symptom of an acute neurological illness or a medical illness or a remote neurological injury, which is now producing a seizure, or you don't find any cause. So this is what it is. For example, the seizure may be a symptom due to an acute meningoencephalitis. So that's an acute neurological illness. Or it could be a septicemia, and then the patient has a seizure in relation to a medical illness, sepsis. Or it could be a remote neurological injury. The patient might have had a head injury 10 years back and now is presenting with a seizure. Or the patient might have a calcific focus due to some old, granulomatous inflammation of the brain that has healed, and then it has produced a calcification, and at some point it produces a single seizure, and then the patient comes to you. So that's what you mean by a remote neurological injury. Or sometimes you don't find a cause. So that's the kind of a schema that we have to adopt when the patient comes to the ER with a seizure. Then the next important point, yes, the patient has had a seizure. Now, the next question is entirely up to the ER physician or the ER neurologist who's there, who's been called. How extensive and therefore how expensive should the diagnostic evaluation be? Can you have some kind of an algorithm where you can use simple diagnostic evaluation, the most minimum that is required to reach a diagnosis? or do you do hundreds of tests? No, that's up to you. I mean, it's all, so if the better the quality of information, the lesser the investigation that you need. And so that's a very important point, and we have to be cost conscious all the time. That makes us better clinicians also. And then you have to always ask this question: what is the likelihood of a recurrent attack? And then will the treatment with anti-seizure medicine significantly reduce the risk of subsequent seizures? That's another question that you'll have to ask. And whenever you start any treatment, what are the risks of that particular treatment? And then most important is the ASM treatment, the anti-seizure medication that you choose. Is it appropriate for this patient at this time? That's very important. For example, somebody has a liver injury and then has generalized epilepsy, and then at that time valproate, although it's a drug of choice, in that liver setting, that particular therapy may not be appropriate for that particular patient at that point in time. So that's another very important point. So you have to use your knowledge to the benefit. So let's now come to the scenarios. So you imagine that the patient has arrived at the ER, and a patient has come with a seizure. And then you find that this patient already has epilepsy. So that much is known. So now you want to know, in this particular patient, why did this patient who's having epilepsy and who's been diagnosed as epilepsy is on medication, what is the reason for seizure recurrence? This is quite common in our settings. They come to the ER. So then you have to go through this list. The list is, first thing is, did the patient actually take the medicine or not? So AD non-compliance is a very common thing. The next important question that you'll have to ask is, has there been sleep deprivation, alcohol use, drug abuse? That's becoming pretty common nowadays. At least 30% of young people who come to our ER with seizure, we find at the end of it that they have used some kind of recreational drugs. That's something that we have to keep in mind. Is it a focal or a generalized epilepsy syndrome? That's another thing that you have to determine. Is the anti-seizure medicine appropriate for that particular syndrome? If it is appropriate, then is the dosage correct? And then every time, even in a patient with known epilepsy, you have to always ask this question: is this particular seizure that the patient has come to you, is it a non-epileptic seizure? So this completes that list, the checklist that you always have. So that's what you'll have to do. And when you have this kind of a checklist in a patient with known epilepsy, and then you find out there's no real immediate rush, because this patient has already been investigated earlier. There's no point. We have now seen that at every seizure recurrence, we find that whenever they go to the ER, they'll get a CT scan done, or they'll get it. So the patient comes with multiple scans, which actually is not really needed at all. So that's the point. So we must always know the classification of a first seizure. We'll come to that now. So provoked. So most of the time, it could be a provoked seizure, which could be a toxin, medicine. We just now mentioned about the toxic cause, the medication, or metabolic factors, acute symptomatic seizure, and an acute illness such as stroke, trauma, brain injury, encephalitis, meningitis, and a remote symptomatic seizure caused by a pre-existing brain injury, seizure associated with an epilepsy syndrome, the already known existing seizure, but the first ever time they are coming with that. And some of the examples of this thing is alcohol withdrawal, barbiturate withdrawal, metabolic conditions like hyponatremia, we all know this, and drug of abuse. This is very important. Always remember, don't hesitate to ask this question. And if you are hesitating to ask the question, better do a toxicology profile in the slide and then get it. Medication. Some of our medication can produce seizures by themselves. So that's important. So let's go to a clinical scenario. These are all real scenarios. It's not imagined. These are some of my own, our own patients who have come. See, this 15-year-old male has reached the ER after having suffered a generalized tonic-clonic seizure. This is the history that they gave 30 minutes ago. So he's not had any aura, and that seizure, according to them, has lasted about 5 minutes. By history, there's a first ever time. History, first ever time. Neurologically, he's intact. By the time he has reached the ER, he's reported to the ER within half an hour, but he's actually absolutely intact. He's neurologically intact. He's cognitively intact. No neurological deficits, no constitutional signs, no rigidity, nothing, no family history. What I would do in this patient is actually, if I'm this thing, I would get an EEG done. And this patient has this EEG. This patient has this EEG, and this EEG shows a burst of generalized polyspikes. And you know that, yeah, I mean, this is a genetic generalized or an idiopathic generalized epilepsy syndrome. This may have been his first seizure. We don't know. So that's what. So this particular EEG tells you many things. One is that it could be his first seizure, first ever seizure, or it may not be his first ever seizure, and we'll tell you why. We reviewed the history, and then because we asked some leading questions, once you see that particular type of an EEG, then you go ask some, we ask for history of whether he's had some kind of myoclonus. And he said, yeah, whenever he's sleep deprived, sometimes he gets some early morning myoclonus when he wakes up in the morning. Sometimes his hand just goes off like that. So that's the point. The point is that this is not his first ever, it is his first ever big seizure, but it fits in with this. These myoclonus also are, kind of mini seizures. So it's not his first ever seizure, but it fits in with this syndrome. And so you make a diagnosis of a juvenile myoclonic epilepsy syndrome just by the circumstance that it has happened. And the second thing is that EEG gave you the clue. That's it. So here, generally, we don't treat if it is a first ever seizure, but in this particular case, in a juvenile myoclonic epilepsy, even if it is a first ever generalized tonic-clonic, it's better to treat. So here, you would like to choose some broad spectrum drugs, valproate, levetiracetam, or lamotrigine, perampanel. These are the drugs that are generally effective. The best of it is, of course, valproate. But, if it's a female, then you would use levetiracetam. But you should not use the sodium channel drugs like carbamazepine or ferritin. And the most important thing, when you see an EEG like that, there's no real need for neuroimaging. That can wait. I mean, you can just send them off, treat them, and then send them off, and then you can do it at a later point if needed. That's it. So that's what it is. So this is what is called a judicious use of investigation. So what is an acute symptomatic seizure? We'll come to this. So the definition of an acute symptomatic seizure is there is some insult that has happened to the brain. And if a seizure has happened within 1 week of that particular insult, and that insult can be either a stroke or a traumatic brain injury or an anoxic encephalopathy or an intracranial surgery, whatever it is, there has been a transgression of the brain's mechanisms. And if a seizure happens within a week, then you call it an acute symptomatic seizure. That's anything longer than that becomes what is called remote symptomatic seizure. So it is also during the active phase of a central nervous system investigations or within a 24 hours of a severe metabolic derangement, for example, hypoglycemia, hyponatremia, and all that. And acute symptomatic seizures are form about a third of patients with first ever seizures. Now we'll give another 15-year-old. So we saw a 15-year-old male, the previous one. Now you have the same 15-year-old male who's come to the ER with a history of recurrent left focal sensory motor seizure. The patient is complaining and saying that, from the left hand, some electric shock-like sensation is coming, is rising up, and then having recurrent jerking of the left arm, the left face. And it's been having it for the last 2 days as he appears in the ER, repeated episodes like that, each episode lasting 1 minute. He's fully aware of the seizure. So this is a focal sensory motor seizure with preserved awareness. That's the classification. Every time he gets a seizure, he has a very mild postictal Todd's paresis for about 5 minutes. He's not able, he's got fine motor skills are slightly impaired during that time or soon after that. Between the attacks, he's normal. And he doesn't have constitutional symptoms. So which means that it doesn't have any symptoms or signs suggestive of an acute neuroinfection like meningoencephalitis. And there's no fixed weakness to say that he's had a stroke or something like that, and he's not had a head injury. So let's see what it is. So this is a fairly common scenario in our setting, and here. So this is likely to be an acute symptomatic focal seizure. 2 days history, just repeated. Very likely a structural lesion is to be present. This is the situation where a neuroimaging is needed, not the EEG. So you see how we are now. So here we would place all our emphasis on neuroimaging, and not any focal seizure in the acute setting will need a neuroimaging. There it is. In our country, this is quite common, and you see this acute. There's a nice ring lesion with a signet sign. So that's a neurocystic circle. Cyst is quite common. So here the choice of anti-seizure medicine, as opposed to the previous case, here, the drugs that were contraindicated there are the ones that you can use here very nicely. Carbamazepine, phenytoin, phenobarbital. Levetiracetam is a broad spectrum that can be used, lacosamide, levetiracetam. So you can see a large number of drugs can be used. Even valproate can be used in this situation, not a problem. So the choice in a focal epilepsy is more. That's quite obvious. So so we saw an acute symptomatic seizure, focal. Now we come to a 14-year-old girl. And you see this is an acute onset of continuous focal seizures, just like the other 15-year-old boy we just now saw. Continuous focal seizures of the right face and hand. She's fully conscious. Speech, no dysphasia, but she's dysarthric because of jerking of the tongue. She's afebrile. She has no constitutional symptoms, and she's completely well previously. Suddenly, explosive onset of continuous, what we call, I'll show you this. This is a girl, 14-year-old.
Close your mouth.
See, she's getting those. It's continuous. It is what is called, and you can see the dysarthria there.
Which class are you studying?
See, she's got dysarthria, not dysphasia. And that's epilepsia partialis continua of the tongue. And you can see that, mini jerking of the thumb. And but she doesn't have any, you see, she doesn't have any significant weakness of the leg. So she's fully conscious, but she's suffering because of this continuous seizures.
The other side? No. Keep your head straight.
Fully conscious.
Look up. Up. மேல பாருங்க. கீழ பாருங்கம்மா.
She's fully.
நாக்கு வெளிய நீட்டுங்க போ.
You see the seizure, the jerking is not stopping. So here again, very important. So what are we dealing with? The previous one showed a neurocystic circle cyst. In this girl, you saw focal. You see that? The thalamus is hyperintense, and you can see that. You see the perisylvian insular area is hyperintense. Insular ribbon is hyperintense, and so that is this is another cause. You see, this is an acute focal encephalitis syndrome. Acute focal encephalitis syndrome, but no fever. So it's a non-infective focal encephalitis, and the CSF is normal. Autoimmune panel was positive. You see, the GAD was positive in serum and CSF, and she got 5 days of methylprednisolone and multiple anti-seizure medicines, no response. She became psychotic on day 4 or something like that. Could be steroid-induced, or could be the or the disease itself. So we decided we just gave her, instead of IVIG, we just gave her a 1 gram single dose of rituximab. This was in 2017. And within 2 weeks, the same girl is completely normal.
அந்த ஜெர்க்ஸ் எல்லாம் ஒண்ணுமே வரது இல்ல. பேசி பாப்போம்.
நானே பேசிட்டு இருக்கேன்.
You see, she's recovered very well.
கையில அந்த ஜெர்க் எல்லாம் ஒண்ணும் வரது இல்ல.
See, that's it. So you see the dramatic improvement. So you see that the cause of seizure when they presented with the ER was a focal motor seizure. And the cause in this case is a focal encephalitic syndrome, probably autoimmune. Again, another very important component of the ER work that we have is the postpartum seizures in the ER, and that is a very challenging subject because, this is a 25-year-old lady, my colleague Praveen Chandar is examining her fundus because you can see here that, the 5th day postpartum, 3 GTCS in a span of 6 hours. She came with headache, intermittent blurred vision, blood pressure was 150/100, urine showed proteinuria. She had papilledema, but no lateralizing deficits. So this is a classical case of a stress syndrome or postpartum eclampsia. You can see the changes that are seen, that the occipital lobe, there's a raised ICP, the blood pressure is high. And here the treatment is not anti-seizure medicine. The treatment is magnesium sulfate. You see how in different conditions you give different medications. The seizure is the same, but the medications keep changing. And so you just give her max sulf and you reduce the blood pressure with amlodipine, and that's it. She's become normal. So that's it. So if we miss this point, then she can become cortically blind and so on and so forth, and a lot of issues can happen. The other important cause is this, you get sinus venous thrombosis in the postpartum period. So that's a very important cause. We all know that, and you can see that that's dense delta site there, and that's a dot sign on the scan. That's a cortical vein that is thrombosed, and so cerebral venous thrombosis, headache, vomiting, left focal motor seizures, persistent mild left hemiparesis, papilledema. Here now the treatment is heparin, low molecular weight heparin, acetazolamide, and anti-seizure medicine. So you see, the cause of seizure determines the specific medication that we have to give, and so that's what it is. And then I'm going to show you a couple of more very interesting aspects. The confused patient in the emergency room, a 72-year-old lady with a mild chronic renal failures, mild stable medical renal disease, creatinine 2.5. But in the last 2 days, has become dull. She's slow in reaction time. She's very confused. She's got a low-grade fever. She's been treated with urinary tract infection. Obviously, she's had a urinary infection. Cefepime has been given. You can see this lady, she's conscious. She's conscious. When you see her response, very slow. Very slow. See, she is obeying, but ever so slowly. My colleague, Dr. Satish is examining. Malcolm Jairaj is also examining. So two of them are struggling to. So she is aware. I mean, she's awake. She's obeying, but you see her reaction time is extremely slow. Extremely slow. You see that? See, that's the story. And then sometimes she has these kind of non-clonic some rhythmic movements. Anyway, that's it took a very long time. You see, it's important for people to realize, what. See that? So Satish has managed to get him to sit up.
98.7, sir.
See. Very difficult. We are trying to find out if there's some asterisks. But obviously she's not, although she's not fully cooperative, but she obeys. So that much is there, but very slow reaction time. And here the EEG is more important than imaging. And you can see here that this is what is called a non-convulsive status epilepticus. And you can see that it's more than 2.5 hertz. That means in every second it's got more than 2.5 per second of the spike and wave discharges continuously present throughout. So, so she's in non-convulsive status epilepticus, and that is the reason why she's confused and very slow reaction time. They don't have to be completely unconscious. So that's a very important message that we have to see. Elderly person who's becoming slow in their reaction time, An EEG is a very important tool. And you can see that this is going on all the time. So this is a cephipime induced non-convulsive status epilepticus. So when you give cephipime in a compromised renal function, even one dose is enough to transform the brain into a epileptogenic brain. So that's what has happened in this lady. And you see what happened? We just gave her, see, she's normal. See, she's she's telling her name. So she's fully conscious. You see, the EEG has become normal. So the EEG has become normal with the midazolam, and that's it. So it's completely transformed. And you withdraw the drug, that is the cephipime, and then you just wait, bide your time, and after some time they become normal. So that is another very important message that we have to give. So always keep this possibility in mind. And all these patients have approached the ER. Now here is a 57-year-old diabetic, 10 years, irregular medicines, last 36 hours, episodes of confusion, repeated episodes of confusion. You watch his eyes will slowly drift to the left, and then he'll have an involuntary smile. See, the eyes are, and then this is a funny little smile that he gives. It's involuntary. The eyes are drifting. You can see that there's a nystagmoid eye jerking to the left. And in between is a little better, but he keeps having these episodes continuously, last 36 hours. He's never had seizures in the past. And so in this setting, you see that the seizure is actually beginning in the right occipital cortex. Very nice, beautiful rhythm that is happening. As the eyes are going to one side, there's a very nice rhythm which is happening. So there's very clear there's a focal seizure which is arising from the occipital cortex, and the blood sugar 600, urine ketones negative. So it's a non-ketotic hyperglycemic. It's another example of an acute symptomatic seizure, but in this case, it is a non-ketotic hyperglycemia. And you can see that, that's where these are the changes that happens in acute hyperglycemic status. And so that's what happens. And then the patient, once you control the blood sugar and all that, they become completely normal. And this EEG, 48 hours later, there's no further episodes of seizures in that patient. Very important. Sometimes you may have to intervene surgically for these patients. And because their seizures are not stopping, they come to the emergency, they never leave the emergency. They're just stuck. I just show you a couple of examples. And you see this girl. She's intubated because she's unconscious and she's having continuous seizures. It's not stopping. She's in status epilepticus, left hemispheric, because it's more focal.
This will be the index seizure you can take because there were some jerks on the.
So this was in 2016, and she was in this state in JIPMA for about 3 weeks, and then she was shifted to our center, and she underwent an emergency hemispherotomy. And this is another boy with Rasmussen's encephalitis. And he's not able to hold his secretions because this is continuously he's having, not able to swallow. So he also had to undergo an emergency because it's not stopping at all. It suddenly started off and he couldn't hold back his secretions too. He couldn't swallow properly and he was having these recurrent seizures. And so that's what happened. And you see that once you did the hemispherotomies for these children, they become completely all right and follow up. This is now 9 years back, and this is about 7 years back. They become all right. Now, the last part is a very interesting aspect. So you have to always keep your, this is during the COVID period, the peak COVID. A 33-year-old woman was brought to our ER with recurrent, prolonged, generalized tonic-clonic seizures, each lasting up to 10 minutes at night between 11 p.m. and 11:45 p.m. So she's had these 3 episodes. She was living as a paying guest, 3 other mates, and she's married but separated, taken to a nearby hospital, loaded with 1.5 grams of phenytoin, phosphonitoin, 1 gram, all absolutely appropriate medication. She was admitted, her CT was normal, blood works were normal. So that was the history that we got. But the problem was with this good dose of all these medicines, she continued to get the same seizures, and she was shifted to RER. And somehow I had a feeling that this may not be real epilepsy. So I see that's me there, and this lady. So I say that you may get a seizure like this. We don't know. So I kind of give her a suggestion, and you see, she starts. I give her a suggestion, and then she starts performing pretty well. I mean, she starts getting these. Same. So her friend says, "Yeah, this is what she got for this." She. And then you see the variability of signs, and that's what we want to show. You see that it's not consistent, it's not never the same, it keeps changing, variable. Sometimes it's the hands, and then there is always this a sense of you see that moaning which is there, which is a sign of desperation. And you can see here now that there is a Gegenhalten. You can see that there's another thing, maxi rigidity. That's another feature that can happen.
It's not catatonic, but Gegenhalten.
Gegenhalten. Some amount of catatonia also can be there, but in this particular case, that's my colleague Vikash Agarwal, and both of us saw this lady, and you see that hand, how it's falling out. Now it's a focal seizure. Now I told her, okay, that's enough of this thing. So we made a diagnosis. So I said, I'm going to remove the current from the other side of the head.
It will stop. Yeah.
So another suggestion that we give.
Slowly it will stop.
You see, it's slowly coming down. Slowly coming down.
Yes.
Coming down.
Very
and it has stopped.
good.
You see, so we could start the seizure, we could end the seizure. And you saw that during the seizure, you saw the variable signs. And this lady was in distress, a lot of psychological issues. So, but the very important point is this is a psychogenic non-epileptic seizure. So that's the point. So, but it's important always to remember that in status epilepticus, you have these timelines. I'm not going to go into the management of status epilepticus. No, the timelines are in tonic-clonic seizure, it's 5 minutes. If it's beyond 5 minutes, it is a status. If it is, and then beyond 30 minutes, then it results in cerebral damage. If it's a focal status epilepticus, you can wait for 10 minutes. And the brain damage can happen after 60 minutes. In absence status epilepticus, it's a little longer, 10 to 15 minutes is required to make a diagnosis, and so on and so forth. So, early status, established status, refractory status, the idea is that you got to catch them at this point. You diagnose them early, you treat them very quickly, and you prevent the progression from this to this, and very importantly, from this to this, because here, once they escape this net and they drop into this state, then the struggle is going to be quite heroic. And the outcome also is not as good as if you catch them at this point and then treat them and terminate at this point. So it's very important to understand this. So all this is extremely important for our understanding. So in summary, management of seizures in the ER needs a highly individualized approach. This is very important. So in my talk, I try to give you various examples. All of them are our examples. It's need to distinguish between epileptic and non-epileptic seizures. Very important. You can change their lifestyle, their lives. Tailored investigations based on clinical scenario. And anti-seizure choice depends on the seizure type, focal versus generalized. Apart from that, the specific treatment depends on the etiology. So at every point, I've tried to emphasize the need to get a good history, to classify, and then to choose the right medication, and then find out the etiology. So thank you very much. So there's always going to be light at the end of the tunnel if your approach is good. Otherwise, you'll be mired in darkness. Thank you very much.
Now, I invite our next speaker, Dr. Roopesh Kumar, for his talk on surgery for intractable epilepsy. A small introduction. Dr. Roopesh Kumar is presently Director of Neurosurgery in MGM Health Center and MBBS from MGR Medical University 1996, MS from MGR Medical University 2001, MCH from NIMHANS 2004. The publications and award over 52 impactful journals and achieved more than 18 awards. Areas of expertise: skull-based surgery, neuro-oncology, cerebrovascular surgery, and epilepsy surgery. Current position is the Director of Neurosurgery in MGM Healthcare, Chennai. I welcome Dr. Roopesh Kumar to give his talk.
Yes. So at the outset, I thank the TANS for giving me this opportunity. And more importantly, it's very important, and I'm extremely happy that I'm sharing the dais with Professor Dinesh, Nayak, Dr. Muthukani, and it's my pleasure to be here. And as you see, both the talks are very brilliant and so useful for neurologists and neurosurgeons. Very, very practical aspects. And it's so basic it was, at the same time, most informative. So what should be done? And I think that is the aim of this presentation. And I will now deviate myself into a topic which is for surgical aspect. So one may wonder why you need to do surgery for an epilepsy, because majority of the time they are managed medically. Yes, absolutely true. Epilepsy is a medical disease and they are best managed by epileptic medications. But there are certain unique situations. Professor Dinesh Nayak showed in one of his cases where an emergency epilepsy surgery was done. So similarly, we have on a long-term basis of, my talk will be concentrating on what are the cases where a surgery will be helpful to treat the epilepsy. Most important, it's not that all epilepsies are surgical candidates. The word intractable. So whenever a patient come to OPD and they have an intractable seizures, intractable definition, they're already on medications to best for the case, to first line anti-epileptic medications in appropriate dosage and appropriate indication. So very important. So we should know for which epilepsy what medication to be given and whether the dosage is right. If somebody is getting seizures in spite of these medications in the appropriate dosage, I think they fall into the category of a condition called intractable. That means adding a third drug may not really help. Those are the patients where you need to do a lot of workup and find out why they are not responding to medications. Is there more we can do for them? So that will be my focus of a topic. So why not we give a third drug and just see that? So when we see whenever there is a failure of first two medications, the chances of seizure freedom by adding a third drug is as low as 5 to 10%. So that we should understand. We see that many patients get so many medications, almost 6 to 7 anti-epileptic medications, but they still continue to show seizures. So what is the incidence of these patients with intractable epilepsy? So roughly 1 in 3 adults and 1 in 5 children, they eventually develop intractable epilepsy in their lifetime. And what is the current scenario? These are the patients who should be candidates for epilepsy surgery, but in effect, they are not happening because of the improper awareness, not a lack of referrals in the appropriate time. So that means that it is a current scenario, not in India alone. I'm speaking on a global perspective. So it often takes 20 years before patients are referred for an epilepsy surgery. That means that patients have tried with multiple medications and they continue to develop neuropsychiatric, neurocognitive dysfunction, and they think that epilepsy surgery is a last resort, which is, in fact, it's not true. And so that is why we need to create awareness on this Epilepsy Day. There are definite indications for epilepsy surgery where we can help them in getting rid of the seizures. Sometimes even the medication freedom can be achieved. So why we should aim for seizure freedom in these patients? Let them get medications and then once or twice epilepsy is okay, we can accept. So whenever you see that they are lost their social life, they are not fit to drive. If they have an accidental injury, either when they are driving, they are crossing the road, it's enough to kill them. And as you see, if the patients are on a lot of medications and every time the seizure causes damage, medications also, they are high dosage, multiple medications, puts a lot of neurocognitive dysfunction and they cannot get into the social life like education, their job, marriage. So many factors come into our society. So it's not that the epilepsy is a simple disease or problem, but it has to be managed very appropriately. More important is something called the SUDEP. So epilepsy is not always fatal, but then this is a condition where we find that suddenly patients are found dead, especially chronic epilepsy patients. So this condition, we do not know why, probably some amount of cardiac arrhythmia, which can cause a cardiac arrest, and then the patients are found dead. So there are a lot of theories and postulate mechanisms on this. So these are also the risk factors involving somebody who's on chronic medications on chronic epileptic patients. So we have a lot of taboo in our society. Once a patient is having seizure, society will not come forward. Family will be very hesitant to disclose it to their work atmosphere, to their class teachers. So it becomes a real social impact in their life. Then they're afraid to get married. So many things happen when a patient is on epilepsy and they're very poorly controlled. So how do we choose that this is the patient for epilepsy surgery? This is the patient who will benefit from surgical procedure. So it's not a simple thing. It's a very, very tailored, a team effort. As you see, the epileptologist is the main fulcrum behind this type of program, wherein they see the patient, they identify. So the medications are given by them, they treat them, but they pick up some patients. So these patients are not doing well. So those are the cases where we need to do extensive workup. What are the three essential things? One is the neuroimaging. It is an MRI brain with epilepsy protocol. This is a specific thing, not the routine MRI. We may miss many things. So whenever a patient we are working up on for a chronic epilepsy, intractable, you should always look at epilepsy protocol, preferably with a 3 Tesla MRI, because I'll show you some of the examples. So because sometimes a 1.5 Tesla or 0.5 Tesla MRI is done, we miss out some important aspects of it. Of course, EEG is an important tool, and not just a EEG, it's the video EEG. That is, put the patient, admit the patient, and observe them for 3 to 5 days. They stop the medications and then allow the seizures to happen and try to pick them where the seizure onset is happening. So that video EEG and the MRI are both hand in hand, very, very important tools to do a proper workup for these patients. Last but not least, is the important is the neuropsychological aspect of them. So how much they're affected by the disease, how much they're affected by the medications, and in case if you want to do resection, whether any additional functional damage you are going to cause or already that is damaged, so you can confidently go ahead. So all these things are done by an experienced neuropsychologist. So these are the three basic pillars of a workup for a patient with an intractable epilepsy. Sometimes, even with this, there are many times where you may not find anything in the MRI. It's called a negative MRI. So that is important. So those patients, we need to go one extra mileage. So there are additional metabolic imaging, we call the PET, the SPECT, especially the interictal SPECT gives you very much valuable information. And now the invasive EEG monitoring has come in a big way, the stereo EEG. So what we do convention is a scalp EEG, but then for those cases where you're not sure where the seizures are coming, if you want to do resection of that particular area, you need to know where exactly the seizure. You cannot be doing a wrong side surgery and then patient getting seizures even after the procedure. That puts a bad thing on impact on the department. So the EEG of stereo EEG is coming up in a very big way, and then I just touch it on the main later of the talk. So when you do all this imaging, you do the EEG, video EEG, and then you do neuropsych, everything points to one particular focus, and we showed them that they may be the ideal candidate for an epilepsy surgery. If we take a broad perspective of epilepsy surgery candidates, basically we divide them into two groups. One is the temporal lobe epilepsy, by far the most common. Almost 3/4 of them fall into this category, the temporal lobe epilepsy. The remaining 1/4 fall into extra temporal epilepsy. So for surgical aspects, we divide them into these two criteria. And so temporal lobe epilepsy, of course, the most important substrate is the mesial temporal sclerosis or the hippocampal sclerosis, typically causing refractory complex partial seizures. So this is the most common indication, the most commonly performed procedure for an epilepsy surgery. Of course, there are other lesions in the same location like tumors, like DNET, especially important, some low-grade gliomas, some cavernomas, and then epidermoid. They also can cause this type of a problem. Coming to the extra temporal lobe epilepsy, there are a lot of causes, most important. I'm not including tumors here because tumors as such, that is a different category. So I'm not going to talk anything about the tumors which cause epilepsy. Of course, one of the most common symptoms where a patient comes with a low-grade glioma. So that is a different discussion, and I'm not going to cover. So these are the cases where the lesion as such causes intractable seizures. So the Sturge-Weber syndrome, infantile hemiplegia, hemimegalencephaly, the Rasmussen's encephalitis, focal cortical dysplasia, and hypothalamic hamartoma. So these are some of the real substrates for epilepsy surgery where they do benefit out of them when we do appropriate workup and then do resection. So no epilepsy surgery talk is complete without mentioning about this mesial temporal sclerosis. It's a topic by itself because it's a very well established technique where we perform this procedure and give them very good seizure freedom, even in fact medication freedom after some time. So we're just going to the case capsule. So he's a 26-year-old male, the normal birth and developmental history, which is the caveat. Actually, majority of the time they may have some delayed cry. There could be small perinatal insult. So the first episode was for at least 2 to 3 per month. This is typical. They have an aura, they have a behavioral arrest, temporal phenomena. So sometimes they have automatisms, they have occasional gibberish talk with the tendency. So it depends on the left temporal or the right temporal involved, the presentations can vary. So he was tried on multiple medications, including all the standard epileptic medications like phenytoin, phenobarb, carbamazepine, everything, but nothing was working for him. And when he came to us, he was on this medication. Oxetol was very high dosage, and then, but still then he was used to have around 2 to 3 episodes per week. So this was an MRI. As you see, if you casually look at the MRI, it may look normal, but then as you see, the very important thing is this hippocampus. So you can see that there's a subtle signal intensity in the right hippocampus, which is slightly higher than the left side. And also you see that this is the temporal horn, which is subtly dilated compared to this side. So these are the telltale evidence that that side hippocampus is not right, and there's something wrong here. So it's a sclerosis. So this is the typical MRI finding. Sometimes you may not find also, if you do a routine MRI, you may have to do an advanced thin section MRI that's through the hippocampus. So we proceeded with the video EEG, and we could record 2 episodes with all pointing to the right temporal origin. And we also did a neuropsych evaluation, and it typically showed both impaired verbal memory and visual memory, but more pronounced on non-verbal memory. So this is something which is important. In a left temporal hippocampal sclerosis, the verbal memory department is more marked, and on the right side, the visual memory is more marked. So these are some of the things which we should look for daily. And in this patient, the MRI, the EEG, and the neuropsych all was pointed to the right hippocampal region as a seizure. So this is an ideal candidate for an epilepsy surgery. He had intractable seizures, and everything is pointing towards the right hippocampal sclerosis, and so he'll definitely benefit from this. So what are the structures which we are going to remove? So there are 2 things: whether you do a selective amygdalo hippocampectomy or you do the typical, what is the most commonly done, the anterior temporal lobectomy with amygdalo hippocampectomy. So this is the commonly done. So that is the anterior temporal lobe which we always remove, because majority of the time they are also involved in the epilepsy, and so we need to remove. Of course, the hippocampus is the most important thing, and of course the amygdala. So these 3 are removed, the typical amygdalo hippocampectomy, the hippocampal sclerosis. Now, this is a brief surgical video, and just to demonstrate on how important and how we do perform, basically it's a short video. So we can see that, so routine ECOG recording is not mandatory, but then we did record and then we established. So that is the frontal lobe and the temporal lobe. So this is the frontal side, that is the temporal side, there's a Sylvian fissure. So we do, in the right side, we can be a little bit generous than the left side, and we can see that. So this is the typical anterior temporal lobectomy where the temporal the polar region is removed. And once we do that, and then we go into the deeper structures, the hippocampus. So we identify the temporal horn, that is the most important anatomical landmark for us. And once we put a patty there, and then we start proceeding to the resecting the amygdala. So here, as you see, here is the most important structures at the depth. So we always preserve the arachnoid. So always it's a subpial resection. So you can see that there's a third nerve, the PCA, the brainstem, midbrain, all are done, are protected by the thin arachnoid. So now we come to the hippocampus. That's the temporal horn. So we do record, we do intracog monitoring. So there is the strip electrode which we place on the hippocampus that start recording. As you see, if the EEG shows firing from the hippocampus, we show that the hippocampus is abnormal, it's pathological. So then we try to remove, and then that is the important structure. So that is the correct structure, the hippocampal fissure. So this is a very important structure, and the landmark, the anatomy is very clear cut. Usually the hippocampus is shrunken, and then we do a subpial resection. We do disconnection. Anteriorly we disconnect, medially, and then posteriorly and laterally. So always we should not do piecemeal removal of the hippocampus, because we may have to subject them to electron microscopy to know the pathology. So that is the head and that is the body, and that is the tail. So we disconnect the tail, we disconnect laterally, and then try to remove always in mass. The whole hippocampus is removed as a single unit like that, so that we can subject something like this in a pictorial representation. So we are disconnecting all around, and then we are trying to remove the hippocampus like this in total. So that is you can see that the head, body, and tail is removed in piece. And then once we remove it, again we do an ECOG and check whether any firing. You can see the EEG was normal, and then so we close. So that is a typical amygdala hippocampectomy what we perform. And this is the structure. It looks like a prawn. We can see that. So there is a head, body, and tail, and that is partly the parahippocampal gyrus is also attached. So we send the whole thing, and electron microscopy examination shows these are the pathological findings, the ILA type 1 HS, so hippocampal sclerosis. So this is the standard amygdala hippocampectomy, and there is a post-operative MRI. As you see, the hippocampus is removed, anterior temporal lobe is removed, the amygdala is removed, and then this patient, as you see, is an 8 years follow-up now. We continue the medications. We don't stop the medications for 2 to 3 years. We gradually come down. He has totally seizure-free, so he himself stopped the medication after 2 years without consultation. He had one breakthrough seizure. We came, and then we restarted the medication in a lower dose, but he's now asymptomatic. So he's now back to his job and his normal social life, and he's now 8 years follow-up, doing remarkably well, no further seizures. So that is a type of improvement we expect after a standard amygdala hippocampectomy if it's a properly selected case. Sometimes you see bilateral hippocampal sclerosis. So there comes the role of typical evaluation. So you don't know which side to remove. Otherwise, the patient may not get optimum seizure control. But this is a 7-year-old boy who refractory CPS since 1 year, also had significant behavioral disturbances. So you can see the bilateral hippocampal sclerosis. So extensive workup. You can see that the list of medications he was on, almost in the highest dose, 5 medications, and still then he was throwing seizures. So we did a detailed evaluation, and then our epileptologist, and we had a meeting, and then we found that the right MTS is epileptogenic. So we went ahead and removed it, and we can see that is the hippocampus, amygdala. So this is the typical. So sometimes when it's a bilateral, we have to be very, very careful in knowing what we should remove. You cannot do bilateral hippocampectomy. Of course, you can do in exceptional scenarios, but it's not the norm. So again, this is a very classical thing Professor Dinesh Nayak mentioned, that when a patient comes to the epilepsy emergency, you should also know what are the non-epileptic conditions, mimics. So like Stoke-Adams syndrome, cardiac. So this is typically, he was a pharmacist in one hospital he was working. He used to get types of recurrent episodes of palpitations. So he was evaluated, he was same hospital where he was working, he was taken, and then they did an ECG that time. They found that there are some arrhythmias wherever he gets. So probably they decided that they'll go for a pacemaker. So he underwent a pacemaker, but even then he continued to have these symptoms, and then he was referred to a neurophysician, and then he suspected that it could be an epilepsy. He asked for an MRI and EEG, and then they got the answer. So we can see that. So this is actually very normal looking hippocampus, but slight hippocampal sclerosis on the right side. As you see here, the whole hippocampus looks, you can see that the whole structural abnormality of this hippocampus. And then we went one step ahead, we did a PET MRI, and we can see that the right temporal lobe was hypermetabolic compared to the left side. So we can see, so we decided that. So this is the one which is causing these type of autonomous seizures. Presenting like cardiac is very common in temporoinsular epilepsy. And so this is the culprit. So he underwent a cardiac pacemaker unnecessarily due to misdiagnosis. Actually, it was actually a seizure. So sometimes very difficult to make out what exactly the patient. So sometimes it can be wrongly diagnosed, and then the pillar to post. And then he underwent surgery, and that is a post-operative MRI, and he is very well now. And then he wanted to remove the pacemaker, but the cardiologist told it's too risky to remove the pacemaker, just implant it. And so he still leaves the pacemaker, but then he's seizure-free. And so not just hippocampal sclerosis, there are many other conditions which in this location can lead to this. This is a typical 14-year-old boy studying 10th standard with a poor scholastic performance, refractory seizures. And what we see here is a small, tiny lesion here. So this is the cavernoma, which is one of the important cause for refractory seizure, again in the parahippocampal gyrus. So they produce these seizures, and then once we remove these, they give a very good seizure outcome. Here we need not do a total temporal anterior lobectomy. We can do selective resection of this cavernoma, so that, and then including surrounding the gliotic scar, so that they can get a very good seizure outcome. Again, so this is again a case. You can see that the enhancing nodule here, intractable seizures since 8 years. So this was a DNET, and then you can see that this lesion again exactly in the medial temporal lobe, and this is one of the important causes. He underwent resection, and HP was a DNET. This DNET is one of the important causes for refractory seizures, especially in children. We do see them, and then they get very good recovery once the lesion is removed. Again, the same location, we can see this is the ganglioglioma, calcification there, again medial temporal lobe. So this is a post-operative MRI, and we can see that the lesion is removed. So these patients do very well after the removing of these lesions, which can cause intractable seizures. So appropriate referral at this time can do a lot. Sometimes you can see that there are dual pathology. So here again, the workup becomes very important. We should know what we should remove. So as you see here, so this patient had a small subtle hippocampal sclerosis, again a refractory seizure in a young girl, and she was not able to study. Her scholarship performance gradually went down because of medications. She also had incidentally another lesion in the posterior temporal lobe, the parietal junction. So we do not know whether to remove the hippocampus or this tiny lesion here, whether to remove that or to do both. So again, our epileptologist did an extensive workup, and then we did the VOEG. All were pointing to the left posterior temporal lobe, and we thought that this hippocampal sclerosis is asymptomatic, and so we decided that we'll remove only the left, the posterior temporal lesion. And we can see once we use very small lesions, sometimes very difficult to search. So we use navigation, the image guidance, to appropriately localize this lesion. And then this patient now is the post-operative MRI. We could remove the lesion. The hippocampus intact. She's 9 years follow-up. She's now into her college. She's doing well. She's seizure-free, and then she's remarkably well. So these are the typical spectrum of temporal lobe epilepsy syndrome. Now, I just go to the extratemporal lobe epilepsy as what are the things which we do for. This is one of the important causes. She's 11-year-old coming with an intractable seizures. And we can see that she was earlier done with an MRI brain, and it was reported normal. And this was a 1.5 Tesla MRI, and she was 10 years when she underwent this scan. And she was on anti-epileptic medications. She did not get much recovery, and she continued through seizures. So when we did a repeat MRI, and again we see that it is not very gradually looking at it is normal, but you see there's a subtle difference between this insula and this insula, and we can see some amount of a crowding here. So then further sequences reveal that this insula, there's a scarring, and then you can see there's something going towards the ventricle. And so this is typical fibrous cortical dysplasia, the mantle sign which is seen here. And we can see, so this is the focal cortical dysplasia. This is pathognomonic of this imaging is very pathognomonic of this FCD, and is an insular FCD. And that is the reason why she's showing seizures, and they don't respond much to medications unless you remove that. So we have to do resective, and then, so because this is an insula and then it's also going towards the internal capsular fibers, you should be very careful so that we do not, because the mantle also has to be removed if you want to achieve good seizure freedom. And this is a PET CT fusion which we did, showed typical hypermetabolism in the right insula. And then we also did fMRI. We can find out that any functional language is there in the, fortunately it is all more on the left side. And this is a tractography, and we can see that the tracks are more medial and the mantle is here, and then we thought we can go ahead and safely remove it using navigation. So we could also record 4 episodes during this activity, all on the right frontotemporal region. So imaging wise, VEG wise, all were pointing towards the right side, including the neuropsychological evaluation, which showed the more of a visual memory disturbances. So then we decided we go ahead. The challenges in these are, they are not abnormal. So tumors becomes easier to identify. These are typically looking normal structures. So we need image intervention. There's a navigation probe which we see. So we need to know where to remove, especially the mantle, which we are going to remove towards the deeper aspect, towards the ventricular region. So normal brain is very difficult to appreciate which is abnormal and how much to remove. So all these things we need to have anatomical guidance and as well as physiological guidance. So we also did ECOG monitoring in this case, which is very important. I just skipped this video quickly, and then we can went ahead and then reset it, and that we can see that is a navigation probe. It is important that the mantle is removed because it is going towards the ventricle, and it is very thin track. So with the help of navigation, we can see we traced the mantle so that we are very sure that the mantle has to be removed. You can see that from here we went all ahead and then removed this, and then this is the intra MRI. We just did an MRI immediately so that we didn't want to miss out anything, because these are normal looking MRI, and the patient may have seizures if it is an incomplete resection. So when we found that the mantle is removed, this is removed, but there is a small residual in the inferior lip of insula. So we didn't want to wait. So we went ahead with the same anesthesia. We brought her back to the ER, to the OT, and then we proceeded again with surgery. And we completed the resection of the inferior lip of the insular cortex. And that is at the end of surgery. So again, we repeated, and that is the pathology. This is a typical balloon cells, what we see in the focal cortical dysplasia, and they do very well if appropriately resected. And this child is doing well. You can see that the post-op MRI, all the abnormal areas are removed, including the mantle, and then she's on follow-up now 4 years and no further seizures. And she's on medications on a small dose. We are eventually planning to taper and stop after some time. This is a very, very interesting case who came to ER. Dr. Dinesh Nayak showed very good examples of how an emergency. So this is one such example. He came to ER and then he was having seizures continuously. And then so we decided that we'll do an imaging because it was all the left focal becoming secondary generalized. And then this is the MRI which we did. And this is a very important thing. What we see is a subtle hyperintensity, the right frontal. But what is important is the perfusion MRI. So this is called the ASL perfusion, and this is the color coding of the perfusion. We see a very bright spot. So whenever we see a bright, high perfused area, we always erroneously diagnose that could be a tumor because of the vascularity. But then you should also realize that this is a very strange instance where we could pick up ictal MRI. So this patient was having subtle seizures even in the MRI room, and that is why the increased blood flow caused this. So actually, this is not a tumor actually. So this is because of the ictal high perfusion during a seizure. We could capture that, and so one should not diagnose this as a glioma. So this is actually, we resected. It was a focal cortical dysplasia again, and so he was resected, and he was remarkably well after the procedure. And we can see that. So this is again a 43-year-old female. It's refractory seizures. As you see the list of medications, and we take it all. Almost you can see 1,600 milligram, very high dose frisium. Why she was always sleeping is because of high medication dosage, and she had typical epigastric burning, shivering. So this is our epileptologist notes. And what we find here in the CT scan is a small granuloma. So in addition to that, and there is some amount of a thinning of the parietal cortex here. Dr. Dinesh Nayak showed that the cysticercus, the active stage. So this is the old healed granuloma. So we need not neglect it. We can neglect it if it is asymptomatic, but then she has a refractory seizures. And so we wanted to know whether it is this particular thing which is causing the seizures or it is something else. So we did PET CT, and then we fused it, and then PET showed a decreased left parietal hypermetabolism. And then we did a video EEG, which also showed that the left parietal neurons are firing. So there was a good concordance between the MRI, EEG, and all pointed towards the left parietal region. So here it's very important that we do ECOG monitoring. So these are the cases where we need, because it's very difficult to pick up the small granuloma or surrounding cortex. So we need this image intense with the navigation and also the ECOG monitoring. And then we remove that, then this child became very well. So this is again a very interesting case. This is actually Dr. Malcolm's case. He worked up in Stanley. So I was called to do the surgery there. This is the refractory seizures in an 8-year-old boy who had a large lesion like this in the parietal lobe. And you can see that the functional MRI, all his leg area was very, very close. And then, so we decided that we will do an awake procedure in him, because this is the one which is causing seizures. All the workup was done and everything was pointed towards this lesion. So we did an awake procedure, and we can see that he's not intubated. Our anesthetists are doing an excellent job here, making the child comfortable. Awake in children is very challenging, but a good anesthetist can help us really. And we can see this is the opening, and there's a normal motor cortex here. We mapped here the motor cortex, and this is the bulging lesion, abnormal lesion. And we resected this. The whole thing was a DNET. So this child continuously threw seizures in the OR, and a very good tool to stop seizures during surgeries, cold saline irrigation. So we kept on irrigating the cold saline, and so the cold saline nicely stops intraoperative seizures, and then we resected the whole lesion, and then seizures stopped. And that itself is an indication that we had done a good job. And we also did an ECOG monitoring post-op. There is a cavity, and this pathology was a DNET, and then the child is doing remarkably well. So these are some of the cases which can cause typically seizures. Now coming slightly to posteriorly towards the occipital lobe seizures. So he's an 8-year-old boy with an intractable seizures, 2 years duration, and he had 3 to 4 per week. Those are again multiple medications. He started with visual hallucinations, and he also had right homonymous synovia. So this was his MRI, as you see. Then everything was normal, but you can see that the left side is scarred, And we can see the difference between the right and the left occipital lobe. You can see this is the normal occipital lobe, and here you can see that the whole occipital lobe is scarred. And so we didn't know whether this is the one which is causing the seizures. Most of these things can be perinatal insults, and we can see already he had hemianopia. That means this is a non-functioning cortex which is troubling him by producing intractable seizures. So this is a condition called urticaria, can also be due to postnatal insult. So we decided that we'll go ahead and reset this region. Now the question is, we can do either disconnection or we can do removal of this. Because it is a non-functional, we decided that we'll better remove this. This is an intraoperative picture, as you see here. So these are the normal parietal cortex. And then we can see that the typical scarred occipital gliosis, and then we resected the abnormal tissue using an ECOG recording. And then this is the intraoperative ECOG, and we can see that there's firing. And then this is the after resection, we can see that there's a flowing. So we knew that we have resected the lesion, and this patient, and now he's grown up. So this is the postoperative MRI. We can see the tailored resection using ECOG, and his immediate postop he was doing well. And then he came to, again after 6 years, remarkably doing well. He's now finishing his schooling, and then he's going to enter the college. So, and he's almost off medications. So this is the something which you can achieve by appropriate case selection and doing a procedure. This is again a similar case we did very recently last month, and she is from abroad. She's 22-year-old, refractory seizures since early childhood because of a perinatal hypoxic insult. She was neurocognitively dysfunctional. She had a lot of neuropsychiatric issues, was very difficult to manage in her house. And then we decided almost the same. You can see this on the right side, and then we resected this area using ECOG, and then she got discharged last week. She went back to her native country. She's doing well. She used to have 2 to 3 episodes every day, and now she's now remarkably well. The family is happy. So appropriate case selection is very, very important. Now the last thing is one of the important causes of refractory seizures is hypothalamic hamartoma. So hypothalamic hamartoma are basically, there are 2 types, either they are sessile or they are pedunculated. The pedunculated ones causes precocious puberty, a lot of hormonal disturbances. The sessile type causes refractory seizures, neurocognitive dysfunction, and they are one of the important reasons for refractory seizures in childhood. It's important to realize this fact and then to do a surgical resection, because medication generally don't work in hypothalamic hamartomas. So this is a gelastic seizures. There are either they can have present the gelastic seizures, inappropriate smile, or they also can the other way, inappropriate cry, daclyatic seizures. So either of the one can be caused by hypothalamic hamartoma. And we can see that they have multiple episodes even within single day. Initially, the parent noticed that this type of smile was normal, but then it took some time for them to realize that this child, after some time, she had changed her morphology, but elastic. She used to have this go back staring, and then because she was on multiple medications, and then she used to come back. And then this patient, we do surgical resection. If it is a pedunculated one into the cistern, we do a skull-based approach and resect these lesions. If it is an intraventricular, we do endoscopic. I'll show the next video. So the whole thing. So this surgery is also quite challenging. This optic nerve, this is a carotid artery, and you can see that the hypothalamus. So you should be extremely careful because surrounding vital structures, the PCOM, anterior choroidal artery, the anterior cerebral. So you need to be extremely delicate structures here, and we cannot put any traction on hypothalamus, but it can cause significant damage to the brain. So this type of surgeries, and so we can see that finally, so that is the last part of the surgery, and we can see that the lesion is removed, and this is using a skull-based approach, fronto-orbitozygomatic osteotomy, and so that without any brain retraction, you can see that is at the end of the resection, that is the bed of the hypothalamus, that's a basilar artery, and there's a so you can see that. So through this narrow corridor, we can get away this lesion, and then this child, 6 years follow-up, occasional aura, no further seizures. She's doing remarkable well. That is a post-operative MRI. We can see that is removed. This again, hypothalamic hamartoma, and we can see here, it is not in the cistern. It is purely intra-third ventricular. So these cases better approached endoscopically or microscopically transventricular. So we can see that. So this is the hypothalamic hamartoma bulging one. So we can see that. So we can see using monopolar. Either we can do disconnection and all around. We can do radio frequency ablation, which is also now coming up. So this hypothalamic was hamartomed using endoscopy, and this child relatively did very well. So the final aspect of my talk is neuromodulation epilepsy. So this is coming up in a big way, and future many more cases can be managed by this neuromodulation. So what are these? So this is a restorative neurosurgical therapy, RNS, the vagal nerve stimulation, the deep brain stimulation, and the laser interferential thermotherapy. So of all these things, the LIT has not come to India, and because it needs a separate software. So maybe it's one or twice it is done as a demo cases, but then but in US it is quite commonly done now, a LIT, and it's not just for epilepsy, even for gliomas they started doing it. But in our country now, the vagal nerve stimulation is now picking up, and whenever we are unable to find where the lesion, where the epilepsy is coming, and it is a polyform pharmacy and refractory seizures, we can try to do vagal nerve stimulation. It was started in 1997. The US FDA got approved, and then here it's not a very major procedure. It's a simple procedure we do in the neck. So we do not know why the vagus, what the vagal nerve has to do with epilepsy, but then there are a lot of theories behind this. So through the tractus solitarius, the nucleus have a lot of vagus nerve, has a lot of cortical projections. And so when we stimulate, so when we modulate the vagus nerve, it tries to suppress the epilepsy. And it's not that, unlike other procedures where you get a very good seizure control, here fairly you get a good control, and then you'll be able to reduce the medications for a period of time. So this is the way we do. We identify, we explore the neck and put this electrode, and then there's a pulse generator, and then it keeps generating. So the cost is the deterrent here. I had only one case like this because of the cost, and we can see those. So this is the one. So we put it up in the neck. So we identify the vagal nerve, and then we pull it up, and then this is the electrode which goes around. It's like a spiral. So you put it up around the vagal nerve, and then you bring that electrode and then implant the pulse generator into the below the clavicle. And then here, the seizure outcome is typically done in children above 4 years if they have the refractory seizures. The long-term research study now find that 50% of patients experience seizure reduction by 50% in 2 years. And the effect of this seizure control is much better at longer time. So the more you wait, and the more better is the seizure control with this type of procedure. So to conclude my talk, so epilepsy surgery shouldn't be considered as this is the last resort. Let us just refer only when all the medications fail. It's not like that. In appropriate cases, an early referral actually improves the outcome, especially in children with a neurocognitive, with a good social message. Consider early surgery to improve outcome, especially for in children with refractory seizures. Very, very important is that it's a very good teamwork. A good epileptologist and a good radiologist, a good neuropsychologist helps in identifying where is the lesion to be resected. Because for neurosurgical aspect, it is a mechanical job, but then there's a lot of brain behind. A neurosurgeon also should start thinking like a neurologist, like an epileptologist. And if we start working as a team, then we also come to know that we understand the epilepsy on a global aspect, and it is very, very essential that we also put our brain into it, and then we have a very good teamwork to give a very good result. Because a wrong surgery, when you start, and a wrongly indicated patient, and if the patient outcome is not good, then it puts brings down your enthusiasm in this case. So it's very important that it's not that every case you start with working up and do surgery. It's not like that. So we have very good tools now to do. A lot of scope is now coming up, and still there's a lot of, so many patients are there with intractable epilepsy. Very few are getting managed surgically. So there's still more, lot of things to be done, create awareness, appropriate referrals, and then proper epilepsy center they have to be attending, and with a good team effort, we can really wonders. So thank you very much for this opportunity.
Very good talk, Roopesh. Nice. What's the battery of cases? It's good. Yeah. And you normally do total what is that, anterior temporal lobectomy along with amygdala or just selectively do amygdala alone?
Oh, sorry, I usually do anterior temporal lobectomy also. I generally don't do amygdala because many studies are now coming up that the seizure outcome is much better. It was Professor Yasser who propagated this idea of a selective amygdala lobectomy, but it was not accepted on a larger aspect. So many prefer to do anterior temporal lobectomy also because they are also responsible for seizures. So it's better that we do that for better outcome.
And surgically also that is a little
becomes easier also. Yeah. Otherwise, if you do too much of retraction, the depth becomes more. Resecting the amygdala is also much easier if you do an anterior temporal lobectomy.
Good. think everybody's exhaustive talks.
Roopesh's talk was really good. Very nice cases and very well explained and very, very thorough job. Excellent. Congratulations.
Thank you, sir. I always look forward to work with you.
Let's see. Yes.
And again, Dr. Roopesh, that gliatic region, when you resect, how will you decide when to stop? Of course, you are using ECOG, but other than that, just you simply rely on the navigation, because you told navigation, but most of the time when we open, it won't help us.
Navigation is only to reach. Navigation is only to reach the area. Once we start resecting, the navigation becomes, it's all by the texture. Example, if it is a cavernoma, so we can very well know, because it gives us a good idea. If it's a DNET or all those things also we can know. The problem will come if it is like a calcified granuloma, which is too small, but that is alone is not the problem. So you can see that the surrounding cortex was also thinned out, just gliotic. So there probably ECOG guided resection. So we use ECOG a lot. So whenever we are not sure, so more than the structure, ECOG will guide us how much to resect. Because the one case which I showed, the first case of epilepsy, the occipital of epilepsy, the lesion, the scarring was, when we resected the small area, the ECOG was still firing. So our epileptologist told, no, that is not enough. Still it is out of firing. So we extended resecting all around, and then we achieved, only when we achieved a ECOG silence, we stopped resection. So those cases, ECOGs really helps. And epileptologist in the OR. So that is very, very important. So otherwise we not know, we'll be left blind. So
True, yeah. That's good, nice.
So that was a nice discussion by all the three people, and we had a nice talk about the basics of EEG, and Dinesh Nayak sir about the emergency treatment of epilepsy, and the surgery talk by Roopesh Kumar sir. Any one of you want to ask any questions, you can ask. Still 170 people are there. You can start asking question if you want to ask.
It's for Dr. Dinesh Nayak, sir.
Yes, sir.
Yeah, this regarding that imaging, you are telling, your talk is about the seizure in the ear. For us, to my knowledge, it's easy for us to do imaging rather than EEG on that emergency setup.
Correct.
Still think
No, I
that.
agree, sir. I agree. The problem, I agree. I mean, there's no doubt about it. What I'm trying to highlight is that, if you know the cause, if it's a known patient with epilepsy and who's come with a breakthrough seizure, and the patient is fully conscious, aware, and all that, then you probably don't need an immediate imaging. If the patient has already had an imaging done some time ago, the problem is, what I'm finding in many times is that each time a seizure happens in a patient who's already known to have seizures, and they keep coming to the ER, each time they get an imaging done. I think that's the message I just wanted to, not to say that you should not do an imaging, but we can be more kind of discriminatory in that. That's all. That's the point. But I agree fully. I mean, getting an imaging done is just only a 3-minute job, because you just put in and then you get the answer very quickly. But it can be normal, and if it's normal, then again we don't know what exactly is the syndrome. So actually, you need both. One will be needed if you are strongly suspecting a structural, for example, a focal epilepsy. It may not be that important if it is a generalized epilepsy. That's the only thing. But then you got to be very careful. I agree.
Thank you, sir. Thank you.
So do you, again, so a question to the Dinesh Nayak, sir. So if the patient, many times they come with a scan, and then the problem is that the scan is done a very substandard quality. You will not be able to pick up what it is. So what is your experience on, so are you,
I have a very conservative approach on scanning. In epilepsy, that is. use it very discreetly or discriminately. The scenario that you told now, the person has come with a scan. A scan maybe 0.5 Tesla or maybe 1.5 Tesla, fine. May not be a good scan, right? Not the volume acquisition scan and all that. That's fine. And the patient has come with seizures. That you have also excluded, something like a stroke or other things and granulomas, all that you have removed. Once you've done that, then I will do a good scan only if the person becomes drug resistant. I will treat the person clinically. I will not do a high quality MRI if the lower quality MRI is plumb normal or is not going to add any extra benefit. Then I will use a good quality MRI only if that person becomes drug resistant. That is the time I will do a proper, very good volume acquired multimodal imaging of the scan. That is when I will do. That's what I meant. Just to, if the basic MRI is normal and if the person is not drug resistant, I will not do at that point. That's what I meant.
There's a question in the chat box whether it is legally permissible to do epilepsy surgery without a fellowship. My understanding is that if your institution where you did your postgraduate training, you have been exposed to epilepsy surgery, the whole gamut on all the assessment, including imaging, EEG, and the psychological assessment, and you know how to do it, I don't think there should be a problem that you should do a separate fellowship. That's my understanding. I would like to know what the others feel about it. And wonderful talks, Dr. Muthukani, Dr. Dinesh, and Roopesh. You showed the whole gamut of case things, which is useful to all the general practitioners and the other end of the spectrum, the neurosurgeons and neurologists. Thank you very much for being here. I would like to hear your opinions on this, whether a fellowship is legally necessary for the surgical procedures.
As a surgeon, I think, again, it's important where we got trained. I think if you have got trained in a proper setup during our MCH or a DrNB, I think that is good enough. So there is no need to do unless you are having a passion. Because when during our days, there was no fellowship. So fellowships all started only recently. And now there is a urge for all the young neurosurgeons to do some amount of fellowship, whether it is 2 weeks or 3 weeks. It's just go to a center and 2 weeks you do some observation and then you put your fellow in epilepsy surgery. I think that again is not a correct thing. So if you want to dedicate yourself into thing, I think you should spend a good amount of time if you are not got exposed. Otherwise, if you have a recent basic understanding, basically you continue to learn only after your degree. Nobody gets, during your MCH, it's very difficult to learn everything. So considering the workload. So if you are, yes, today's scenario, it's good. You can, if you are not exposed properly, but if you have a very good center doing a wonderful epilepsy work in your institution, you can, I think, go ahead doing it. Maybe in 1 or 2 initial cases, we can call your mentors to be around, and then in their supervision, we can do till you get confidence, and then you can, anyway, it's not the individual work, it's a whole good teamwork. So with a good team, and if everybody is in the same sync page, we can explore this area.
I fully agree. Absolutely true.
It's legally it is not necessary, but obviously we know what they're doing. Not only ourselves, the neurologist has to refer. They know your job, your skill. They don't refer, just like that. So unless we are capable enough, it's better not to touch. We have many other cases to do. Why unnecessarily spoil somebody's life by doing just because you want to do? That everybody should have that responsibility as a neurosurgeon. So of course, obviously as a teamwork, it's not that possible that they just give a case to us if we don't to do. That's the most important thing, hopefully. That's
so one thing is important in epilepsy surgery is that unlike tumor surgery, where you are removing abnormal, majority of the time it's a normal looking brain which you are removing. So that is very important. So that some amount of a conceptual thinking, understanding is very vital. You should think like an epileptologist. You should think like a neurologist when we do when we are an epilepsy surgeon.
Question in the chat box, sir. which is the ideal anti-epileptic drug in pregnancy?
Okay, very good point. It depends on the syndrome that you're dealing with. But nevertheless, most of the newer anti-seizure medicines are good for pregnancy. That means what we are talking about is non-enzyme inducers. Some of the best medicines for pregnancy, the safest ones are levetiracetam. That's the safest probably. The incidence of malformations is less than 1.5%. That's very, very low. The next is lamotrigine. So these are two extremely safe drugs. Oxcarbazepine is another very good drug. Among the first line, carbamazepine is very good. Phenytoin, no. Phenobarbital, no. So levetiracetam wins hands-on. Lamotrigine is another excellent drug. These are the two, and oxcarbazepine. So these are the ones that are very safe in pregnancy.
What
The
about
ones that you should
riveracetam,
not
sir?
use. Sorry?
Riveracetam?
Well, we don't have much data on it, but it should be something like levetiracetam. But levetiracetam has got a huge database. So I'm talking from that. Levetiracetam is still being studied, but it should follow levetiracetam. So that's true. So that's the basic point. Almost all the newer anti-seizure medicines are good for pregnancy, but the older ones, we have to be careful. Valproate is a strict no-no during pregnancy. So that is the absolute no. The others can be used, it's not a problem. But the other important thing is that most of these anti-seizure medicines, the levels start falling in the second trimester. So preemptively, as soon as they reach 12 weeks, you have to increase the dose by 30 to 40%. Levetiracetam, if somebody is on 1,000, you have to make it 1,500 without waiting for a seizure to happen. Just make it 1,500, 1,750 straight away. If it is lamotrigine, you have to double it, immediately double it, just double it, because the levels fall down dramatically. So you should not wait for a breakthrough seizure. So these are some of the trick points. Every anti-seizure medicine has to be increased minimum by 30% up to 70%. If you do that, most of the time, 9 out of 10 times, the pregnancy will be absolutely uneventful. But you have to do it preemptively. So when you counsel itself, first thing I'll tell is, see, now you come back when you're 12 weeks, because I'm going to, you have to increase the dose by 30%. And I will tell that, why we are doing it is, if you're now taking 1,000, because they get very worried, oh, we are doubling the dose. So I'm telling, at 1,000 milligrams you're taking now, your blood level is 10 going level. Now, if at 12 weeks, if I don't increase it to 1,500, the drug level at 1,000 will become 8 or 7. But if I give 1,500, it will remain at 10. So to remain at the same blood level, you have to increase the existing dose. So finally, the blood is getting only the same level. But to maintain that same level, you have to give a double dose or a 1.5 time dose. That is the message that every neurologist should give, very simple messaging. And you will see that the results are going to be very good. 12 weeks is the time when we have to, second trimester beginning, 12 to 13 weeks. The patient is seizure free, no problem, nothing. By the 8 weeks, your organogenesis is also over, most of it. And at 12 weeks, 13 weeks, 14 weeks, you just have to increase. And at the 18th, 20th week, anyway, you're going to do a fetal malformation scan. And that's it. That's all. And you maintain it till delivery. As soon as the delivery is over, within the first 3 days itself, you can bring it back to the original, whatever pre-pregnancy level. That's it. Very simple. If we maintain these 3 simple facts, 9 out of 10 times you'll get out unscathed. So my humble this thing to all the neurologists, neurosurgeons who are looking after these patients, just give them a lot of confidence. Just have to increase by 30%. Then that's all is actually needed. Yeah. It's very simple actually. If you give them a lot of confidence, they'll become all right.
What about lactating mothers? Do the same precautions?
Yeah, no problem at all. Never stop lactation, whatever the anti-epileptic drug. This is not a problem at all. See, how much ever you give, ultimately the amount of medicine in the lactating milk is so low that it is not going to affect the infant in any way. That is, so that also is not this thing. So we should encourage milk, this thing. Only thing you have to bring back to the pre-pregnancy level. That's all is required.
What about any data on lacosamide during pregnancy?
Yeah, lacosamide is also quite safe, very safe. In fact, I use a lot of it in pregnancy. It's not a problem at all. But I'm talking of purely from the registries. From the registries, the largest numbers and experience is on these drugs. That is levetiracetam, lamotrigine. Lacosamide is now next to lamotrigine in terms of the numbers that are there, because it's a very popular drug, and it's as safe as the others, so it's not a problem at all. That's what almost all the drugs, the newer anti-epileptic drugs, are safe during pregnancy, not a problem, including zonisamide, including topiramate. The one that is actually out of this thing is valproate. Valproate is not good unless you use a drug dosage of something like 300 milligram or 200 milligram, which anyway it's not effective. So there's no point.
One more question about
now we will go for the
cocaine,
questions.
cannabis derivative now the non.
Yeah, I don't have any experience. I'm sorry, I've never used it. I don't know. So I am sorry, I don't know.
Industry is trying to push that now.
Oh, they are now fully into cannabis. I think we are going to go on a high now. I don't know really. To be honest, I don't know. So without personal experience, I wouldn't like to comment. But actually, cannabis works better when clobazam is added. That itself indicates that clobazam is the one that is being, and cannabis is backriding on clobazam, is what my understanding of the literature. I don't have any experience, so I don't know.
So one more question from one of the doctors, sir. What they are asking is that which is the ideal anti-convulsion to start if a convulsion happens? That's what initial practitioner, I think.
Yeah, correct. Initial practitioner, it's always, see, when you're not very sure about whether it's a focal seizure or a generalized seizure, the simplest, safest, and straightforward is to give levetiracetam. The reason is, it is effective for generalized epilepsy, it is effective for focal epilepsy. On the other hand, if you give fosphenytoin or phenytoin, and if the person happens to have something like juvenile myoclonic epilepsy, you don't know what the diagnosis is. Fosphenytoin can worsen it. So, whenever you're not sure of what type of seizure you're dealing with, use broad spectrum drugs, preferably which are intravenous available. So, broad spectrum drug and intravenous available, simplest is levetiracetam. The other drugs which are available intravenous are valproate, then you have lacosamide, you have brivaracetam. These are the medicines that are available as IV. Among the all, the one which is really broad spectrum is levetiracetam. That's it. Brivaracetam also can be used. Nowadays, many people have started using that. But I think levetiracetam and brivaracetam are almost the same. So there's nothing great. Brivaracetam is costlier, that's all.
Does it really help in the neuros? The main reason for us to switch over from levetiracetam to brivaracetam is behavioral, some anger outbursts.
Correct.
But even with brivaracetam also the symptoms continue. So is it really
no, in those who have behavioral issues, say if 20 people with, supposing we put 20 people, 100 are being used, in 100 of levetiracetam, 20 will have behavioral. In those 20, if you switch over to brivaracetam, 5 will continue to have, but 15 won't. That is the ratio. Simple. So out of 100 usage, 20 will have behavioral. Of those 20, if we switch over those 20 to brivaracetam, 15 will not, 5 will have. So that is that is the very simple rule of the thumb rule. So you have to try out in that particular patient. If you're lucky, if it doesn't fall in that 5, he is okay.
It's really helpful in head injury patients. Patients comes post head injury on antiepileptics, mostly on levetiracetam. Then they come with behavioral.
That's a
Before
good
sending
point.
to psychiatrist, I'll change to
Yeah, very good, very good. Excellent, sir. I think I agree with you fully. The other big advantage of brivaracetam over levetiracetam is that within few milliseconds, it enters the brain. It crosses the blood-brain barrier immediately. That is one of the biggest this thing, especially in say head injury, post some status and all that. Brivaracetam is superior to levetiracetam. It very quickly enters. It's the fastest among all any anti-seizure medicine. So that way, I think that is a good point.
When patient attendance also, suddenly, sir, 500 milligram, no, your doctor is going to only 50 milligram. So they are very happy.
Correct.
They will reduce the dosage.
So that our people are very sensitive to these numbers.
Sir, now we will have the last questions.
Yeah. Very good questions.
Okay. Sir, one more question, sir. The previously people were using phenytoin, sir. Even when we are studying, we were using only phenytoin. And if you go to the ward rounds, you can see phenytoin and carbamazepine, which is together it is written, sir. Actually, what is your opinion about that? Because it was done long time back, people used to write both the drugs.
Yeah.
Actually, both should not be combined, no, sir. That is
Very
the
good.
thing. But this was
Extremely.
being done right from the beginning.
More of a
When we were
practice.
studying, it was written. Even now also, if you go to the government hospitals, you can see the prescription, I think.
Yeah, I agree with you.
What is your idea about it?
No, it's correct. I mean, phenytoin and carbamazepine both combined is what is called an irrational combination. There is something called rational polytherapy, so-called rational polytherapy, and so-called irrational. Among the irrational polypharmacy is this combination of carbamazepine with phenytoin and phenobarbital with carbamazepine. But phenobarbital with phenytoin is not a problem. It's a good combination. But the other two combinations are not good because each is an enzyme inducer and each will reduce the level of the other. So the efficacy will come down for each. On the other hand, that is what is called as infra-additive. That is 2 plus 2 should become 4. But here 2 plus 2 in terms of efficacy will become 3 infra-additive. But in terms of toxicity, it becomes supra-additive. That means 2 plus 2 becomes 5, which means that the individual toxicity of each molecule becomes enhanced. For example, carbamazepine will produce nystagmus and dizziness. Phenytoin will produce ataxia. So this is a deadly. So the infra-additive efficacy, supra-additive side effects. Is not a good combination at all. So please avoid phenytoin plus carbamazepine in your practice. Never do that. You can give independently, but never together.
So one more question, sir. In your view, in head injury patients, when to stop the anticonvulsants from the neurologist point of view?
Oh, that's a very tough question. See, okay, it's a good point. Now, if there's a head injury, I'm answering for the neurosurgeons. All of you are very, I mean, you do it.
So
That's your,
even the EEG is normal
yeah,
after
wait.
some time.
We'll put it this way. Early post-traumatic seizures and late post-traumatic seizures. They're two different things. Head injury and early post-traumatic seizure is the first 7 days. If you have seizures, even if there are a lot of seizures, right? You have to treat them, but you can get them out of, and if they, so within the first 7 days, if they had some 10 seizures, for example, they need anti-seizure medicine immediately. And then you can actually stop their medicines over the next 1 month, or maybe, if you're a little conservative, 3 months, no problem. So early post-traumatic seizures, you can taper and discontinue. You can give them a discontinuation trial quite early, very early. The late post-traumatic epilepsy, that means seizures not happening in the early period, but happening only after some time, that means beyond 7 days, usually in the first 6 months. The longer it takes for a seizure to happen after a head injury without a past history of epilepsy means that the scar that has produced, there's some brain damage that has happened during the head injury, maybe microscopic, but it has taken time to produce a epileptogenic focus, which has become a mature epileptic focus. Then only it has produced seizure, which means that that is going to be long lasting. So the chances of late post-traumatic seizures to continue to happen over a long period of time is always going to be there. Such people will require, let's say, fairly prolonged therapy. Let us put it that way. So the early post-traumatic seizures, there may be very early quick seizures, but they don't last long. The late ones are more dangerous. That means the scar has matured or the focus has matured. It's not going to go away. There is a big difference between the two.
Sir, in this context, sir, for example, STH or EDH we operated, we are giving for a quiet period of 6 months to 6
Correct.
months to 2 years. We taper it and stop it with the EEG and all those things. But they come with the breakthrough seizure.
Correct.
How can we proceed? How long you want us to continue again?
That's a very good point, sir. If they come back with a breakthrough seizure, don't give up on tapering. Every year you try to taper. At some point, they may not get any attack. But it's important that every time there is a breakthrough, we have to think that why is this breakthrough? Has there been some metabolic disturbance? See, there is a mild seizure tendency for the person, but that mild tendency alone is not enough to produce a seizure unless there is some other additive effect. What are those additive effects? Maybe, the person might have had an antibiotic, for example, a ciprofloxacin, fluoxetins, quinolones, lower the seizure threshold. So that could be one. Hyponatremia, invariable. The fever, and invariably, if intake is less, they develop mild hyponatremia. From 135, if it comes down to 133 or 132, which is not typically a severe hyponatremia, but in a person who has a small tendency for a seizure, that fellow will get. So if we identify the cause and there is an operational cause, you can taper it even immediately. Okay. Because as long as he doesn't have that second time, you be careful. You make sure that you avoid these drugs. You make sure that your sodium is always on the higher side. Make sure that you sleep properly. If those conditions are met, they need not be on anti-seizure medicine for long. So this is the operational this thing that I'm a very quick. I don't like people to be on long term, very long term. I am a little adventurous. I try to every year. I'll say, okay, now you're all right. Let's try and taper. If the person is willing, we try to taper. you may be, you may not be successful in about 30 to 40%. That chance you have to take, but 60% you'll be successful. And patients will be very happy. They one medication less, but you have to advise them on these things.
Mostly I have seen 80% of patients comes with sleep deprivation with seizure. That's what
Exactly.
most of, they just enjoy stopping the medication, go and enjoy everywhere, party and all, and they come back.
This
is
is
the
the
problem.
point. That is the point. So if we tell them, yeah, we can stop your medicine, but you have to have a discipline. And if you do that, many times they're off. See, to prevent one seizure, which may happen once in 6 months, you're taking medicine every day. Correct. So so we tell them that, and then you see you try to be off it, but at the same time make sure that you live in make sure your sleep is good.
Yeah.
I think that those kind of advices, we can have conversations like that, and it's a dialogue between the patient and it's very interesting, and many people get convinced that okay, now we'll lead like that, because they don't want to be on medication. And it's our job to see whether whether these medicines are really required. Many times it is not required. See, we reflexly give. See, in the initial period, in a stroke, there might have been one this thing, or in a hematoma, we just give, okay, we'll give an anti-seizure medicine. And once you start a medicine, people will hesitate to stop it.
Yeah.
The other important practical aspect also, especially these minor head injury patients, or they have a seizure. Suppose if you're trying to stop medicines, the common question is, when can they be allowed to drive? Because that is something which very commonly we face this problem. So are there any guidelines? Okay, because it's a threat for them as well as the community as such.
Absolutely. That's a very good, excellent question. First of all, generally the Western countries, the driving rules are, if you must be seizure free for a minimum period of 9 months. Some states it is 6 months, some states it's 1 year, but in general, 9 months of seizure freedom with or without medicine. That is not required. What you have to have is the person should be seizure free. Right? Now, if you document that, say for example, now the person is seizure free, medication you are going to now taper because he's seizure free. So you taper and you discontinue in whatever period of time. See, about 30% of the time there is a recurrence. Who is that 30%? We don't know. Let us assume that. Now you take the next parameter. When do they normally recur? 90% of the people who you stop the medicine will recur within 1 month of discontinuation. Another 5% will get a seizure within 3 months of discontinuation. And I mean, if they recur, and 100% of them will recur within 6 months. So if you wait for 1 month, 90% of the people are okay. If you want to be safer, wait for 3 months. So another 5%. So what I tell is that you wait for 3 months, and then you're safe. The person is also safe. Society is safe. That's very simple. And there are hard facts for all these things. So there are studies on this. So at what point you recur? You don't recur at, to 1 year, 2 years down the line. That is a separate issue altogether. It is not because of this. If somebody gets a seizure after 1 year or 2 years or 3 years, that is not because of, it is something else that has happened. But seizure recurrence because of anti-seizure withdrawal happens within 90% is over within a month. Another 5% within 3 months. That's it. So this is a simple statistic we'll keep.
The other common practical question, these patients, head injury patients, again, if they ask us to take alcohol, suppose these patients are on medications.
Yeah.
And of course, if they want to consume alcohol, do they need to have it as an enzyme inducer? should they be patients be looked at increased dosage or?
Yeah. First of all, yeah, I mean, it's, we have to play good cop, bad cop. If you say, yeah, you drink, then they'll say the doctor himself has or herself has said that, oh, I got the permission to drink because my doctor has told. So that is one thing. But at the same time, you shouldn't play spoil sport also. So, that's a very good point. And this question, many people ask. And I'm generally a one who permits people if they're not alcoholics. I mean, if they want to have an occasional drink, you shouldn't play spoil sport and say, hey, you should not at all touch and all that. No, that's like some small pleasures in life. There's not a problem as long as they don't abuse it. So, yeah, I mean, if it's an enzyme inducer like carbamazepine or phenytoin, I tell them that, you take 30% of the dose more the previous day itself. And one more day, and then after that you reduce. That's all. That's the safest way to. And after all, when we tell that okay, you're permitted to drink, we assume that they drink only about maybe maximum 2 pegs, not more than that. That is, I think, social drinking. Social drinking is about maximum 120 ml. Anything more than that is you're just going high.
Now we will go for the question and answer sessions and winners.
Oh yes.
Naveen.
Getting late, quickly you have to finish.
Naveen.
I think even now there are 130 participants still.
Yeah.
So the first question is, what is the yield of epileptiform discharges in sleep-deprived EEG? The answer is C, 80%. And there was no winner for that. And the second question, if EEG is normal, it will rule out epilepsy. The statement is true, false, partly true, none of the above. The answer is false. And the winner is Nagavishnu Shankar.
Oh, good.
Nagavishnu Shankar is there.
Yes, sir. Thank you, sir.
Congratulations, Nagavishnu Shankar. Now, the third question, from Dr. Dinesh's questions. All of the following statements are true for non-epileptic seizures, except the answer is eyes are not kept open. Eyes are kept open is the answer, and the winner is yes, Praveen. Eyes are kept open is the answer, and the winner is yes, Praveen. Praveen is there?
Yes, sir.
You are from which institution?
Sir, Chennai Medical College, sir.
Very good.
Congratulations, Praveen.
Thank you, sir.
Excellent.
Then the fourth question is, all the following anti-epileptic medications are used in juvenile myoclonic epilepsy, except the answer is carbamazepine, and the winner is Dr. S. Praveen once again.
Oh.
Thank you, sir.
Once again is Dr. Praveen.
Thank you, sir.
Congratulations.
Thank you, sir.
Now, the next is Dr. Roopesh's question. The question number 1 is, the artery at risk during amygdala hypopectomy is answer is
Roopesh சொல்லிருங்க.
anterior choroidal artery. Anterior choroidal artery. And the winner is Vinod Kumar. Vinod Kumar is there?
Yes,
Vinod
sir.
Kumar.
Good.
You are from which institution?
Coimbatore Medical College, sir.
Huh?
Coimbatore
Congratulations.
Medical College. Thank you, sir.
Congratulations. Then the last question is mantle sign is characteristically seen in. The answer is focal cortical dysplasia. The winner is Tirubotha. Is there?
Yes, sir. Yes, sir. Yes, sir.
Hello?
Yes, sir. Yes, sir. Yes, sir.
Huh?
Yeah, she's
Yes,
You
sir.
are
Yes.
from which institution?
Chettinad Medical College, sir.
Huh?
Chettinad Medical College, sir. Chettinad.
Chettinad Medical College, Chennai.
Chettinad Medical College.
Excellent. That's a good
So
answer.
congratulations for all the winners. So it was a nice session, and we had nice discussions also, and almost 3 hours now. And
Yeah.
We should thank Professor Dinesh Nayak, sir. So much of inputs and about seizures, very, very practical, because it's all everyday our doubts. So thank you, sir, for clearing all the doubts. It was a very pleasure to have you.
It's a great privilege and pleasure, Roopesh, to listen to your talk. Muthukani was wonderful. Both of you were superb and really good. That epilepsy is in safe hands.
Well, that was a very good, lively discussion. That's very nice. Everybody enjoyed it. It's actually good.
Really good. And so many participants. This is remarkable, sir. It only shows that it's an extremely popular and well-conducted program. Otherwise, so many people at this time of the day is not very good, sir. It's a great thing, Dr. Suresh, sir, Dr. Murugan, sir. Of course, Rajesh. Rajesh, I know from my MBBS days. So we are all, colleagues for the last 35, 40 years now.
It's all credit goes to Dr. Rajesh Babu, sir. He is conducting for the last 1 year continuously without any interruption. He is the main backbone of this program, and it's really going very well.
Superb. Very good. Congratulations, Rajesh. We are proud of you.
thank you, sir.
Really good.
Thank you. Sir. So we will close the session, sir. So I request Dr. Suresh Jayabalan, sir, to give vote of thanks.
Thank you. We are coming to end of this program. First of all, I thank all the speakers, starting from Dr. Muthukani, Dr. Dinesh Nayak, Dr. Roopesh Kumar for their excellent talk, and all the participants and delegates without whom we cannot run this program. And I personally thank Dr. Rajesh Babu for his excellent organizing capacity.